the distinguished seniors, my dear colleagues. So, Gyaan Sangama aims to unite the obstetricians and gynecologists from all over the country to exchange the knowledge and their expertise. So, today we are here for the same. And before we start the program, I request Arun, can you please play the prayer? Let's invoke the blessings of Almighty.
Kurutvang kalyanam arogyam dhanasampadah Shubham kurutvang kalyanam arogyam dhanasampadah Shatru buddhi vinashaya Deepajyotirnamostute Deepajyotirnamostute Shubham kurutvang kalyanam arogyam dhanasampadah Shubham kurutvang kalyanam arogyam dhanasampadah.
Thank you, Arun. So today, ma'am, I welcome our beloved President, Vidya ma'am, and I request her to welcome the gathering. Shobha, can you please introduce Vidya ma'am?
Please, no need to introduce me. Anyway, I'll be giving a talk and I don't want to waste much time. I welcome all the gathering, means all the delegates and all the faculties which are the main part of this program. But I must say that it is my pleasure to welcome our beloved immediate past president of Foxy, that is Dr. Rishikesh Pai. He is very dear to our KSOGA family, and I welcome you, sir, and as well as Dr. Madhuri Patel, who is our Secretary General Foxy, and always she is a part of our various academic programs. And we missed Dr. Rishikesh in our KSOGA conference, of course, but he is always there, and he has visited many of our KSOGA, I think almost major societies he has visited, and he has always blessed us. And we look forward to his as a FIGO representative of our Foxy, and welcome you, sir. And of course, the chairpersons, Dr. Sunita Vadwani, Dr. Shaizes, and our Bela Bhatt, our chairperson of imaging committee of Foxy, and all the people who are joining, Dr. Anu Chawla, who is an expert in endometriosis committee, and this March month is a endometriosis awareness month. So we are doing various programs in Karnataka also, and Anu Chawla is making efforts to do many programs in Karnataka. Dr. Parag Biniwale, our chairperson-elect ICOJ, and Dr. Rosa, who did brilliant work in her, when I was there in her various activities as a chairperson adolescent committee. So we have the brilliant panelists also, Dr. Sneha, Dr. Udayan Sarkar, Dr. Geetanjali Kaur, Dr. Bhanu Shri Lakshmi, Dr. Indira, Dr. Bimba. So all these people will, of course, adore today's platform. And I welcome all the delegates to really enjoy this academic bonanza. We are also celebrating day after tomorrow, the International Women's Day. And we all know that our theme of KSOGA is wellness of women. Our Nagraj sir, who is a patron of KSOGA, he is our backbone of, and always he guides us. So welcome, Dr. Nagraj sir. And our chief patron, Dr. M.G. Remet sir, he will be joining soon. And other people, EC members, our secretary, all are our KSOGA family. So I welcome my KSOGA family as well. Thank you very much for joining us. And I would request to Rachana to introduce Dr. Rishikesh Pai and let us take his blessings and whatever he wants to say to us. Thank you.
Ma'am, is Rajeshri ma'am here because she was supposed to introduce?
Yeah, just see.
Madam is
here, Rachana, I'm here.
Rajeshri joined. Okay.
Namaste.
Welcome you, ma'am.
Namaste.
Ma'am, we welcome you to this program, ma'am. Ma'am,
Thank
I
you,
request you to introduce.
Rachana, so much. Thanks and wishing the program a grand success. Namaste, Madhuri ma'am. Namaste, Bharti ma'am. Vidya ma'am.
Yeah. Rajeshri, please introduce Dr. Rishikesh.
Dr. Rishikesh.
Yeah,
sure. Is it coming on?
It will be there, ma'am. It will be shared.
Okay.
Please share the CV. It's his CV runs in pages, but
I know.
shortly.
Vidya,
Namaste.
just the 4 lines. If you
Sir,
want, I'll
it's
only
indeed
introduce myself.
it's a great pleasure to be introducing you to the KSOGA family and the platform, sir. Thanks for being there and accepting our invitation. Dr. Professor Rishikesh Pai is the Regional Trustee, Asia Oceania FIGO International Federation of Gynecology, which is indeed a proud privilege for all of us in India. He's the immediate past president of Federation of FOXY 2023, and he is the professor of reproductive medicine at DY Patil University, Navi Mumbai, India. He is the medical director of Bloom IVF Group with 11 IVF centers spread across India and is the steering committee member for WHO Global Summit on PPH and subcommittee co-lead for Innovation Equity Forum floated by the Bill and Melinda Gates Foundation and National
I think.
Institute of Health. So,
Thank
as
you.
Madam has said, his CV runs into pages, and it is indeed illustrious persona that we have here today to address us. Welcome to you, sir.
Thank you, Rajashri.
Thank you.
First of all, let me Bharti, and Bharti is now ready for we're coming to the international level now. I don't want to say much, but we are all with you and wish you the very best for that. And our very important Dr. Madhuri Patel is there, our Secretary General, and especially I hope that one day she will become president of FOXY also. That she deserves it also. A lot of hard work she has put in for this. Dr. Rosa Olai was a previous vice president and very wonderful person, good friend of mine, done fantastic work. I remember her newsletters that are there. Of course, Dr. Vidya Thobi, who is the present president and my very good friend. I really look up to her, and she's a fantastic individual. I can also say Dr. Nagraj, who is one of our senior people, and I know him for many years. I really respect him a lot. And Dr. Hiremat has not yet come. All of Hema, Hiremat, all are. So I'm a part Kannada. Na? My father was from Karnataka, so I'm like from part of KSOGA only. So, and then of course Bela is there, our chairman of the committee. Then Sneha is there, another very dynamic individual. Dr. Mahesh Koregal is a great person. I see his name a lot. Is there with Dr. Sashikaran is there, and a lot of other people are there. Dr. Rajeshri, I've already talked to you about. So, I mean, I just is there. I think she has not yet joined. I don't know whether she has joined or not. And so, we have a lot of people here, and I don't want to waste more time. I'm sure you do a lot of learning. I would like to only say that you have to all come for my, presently I'm obsessed with 2 conferences. One is our H3. First time the H3 is coming to India with ISAR and IFS. That is in September in Jaipur, 13 to 15. 23 H3 members are coming. They are spending for their own because it's the H3 conference, and out of the 7 are H3 chairs also. Means the president of H3. They are coming. So it's a very first time a landmark conference is happening. They have a best of H3 and ASRM every alternate year in United States. So ASRM and H3 get together and see how much they respect India. They have given first H3 with ISAR and IFS. First time it has come to India, and not any other country, not African country, not European country, not only India they have given. So it's going to be a good big conference in Jaipur. And then of course my favorite 2013, I had done the All India conference. Now this time Nandita is the chair, I'm the scientific chair, and Niranjan is there, and even Madhuri is a very active person in that conference. So this is this is a passion conference. I don't think anytime this type of conference will take place again. It is in the Geo Convention Center built by the Ambanis. The people in the Geo were telling me one day that the Ambanis have built this center. It is in total loss. They don't make any money out of this center because the way they have built the center is unimaginable. Okay, so you can't recover money from conferences. So, but it is just a brand. They want to, and then there's a lot of things. There are 35 new restaurants in the BKC area. Then the Setu is built. When the Bombay has really got transformed. I can't tell you how much the Bombay has got transformed. So many bridges are coming, so much connectivity, metro. So it's become a beautiful place to stay, and I want you to share that with you. On Saturday, Friday, I've already booked Shankar Ishan Loy. All the three. They're called one of the conference, but here I've called all the three of them. And I again look for the second singer. I say no. Foreigners I'm calling. Already committed. All the top guys from Latin America, USA, Canada, Australia, you name it, I've called them. You're a superb scientific program. So but it is all going to be only if you people come to that program. You have to be a part of that program. We are a big Foxy family, and we will celebrate it together as a one big family. That is what I wanted to do. And all of you, so KSOGA, all the KSOGA important people, all the societies of the KSOGA, Vidya, that's your responsibility. See that all the important chairs, president, vice president,
definitely.
important people. I need the list so that we should not miss out on anyone. All of them should be factored in the conference, because it is our conference. I want everyone to be there. So thank you very much for calling me, and I look forward to meeting you and interacting with you. Thank you.
Yeah, looking forward a great conference there. So we all will be there. Thank you for joining us. Thank you.
Thank you.
Thank you, sir. Thank you, sir. And we will definitely be there.
Rajeshri ma'am.
Yes, thank you very much, sir.
Nagraj sir, ma'am.
Yeah.
Thank you.
Nagraj sir is our own favorite sir, very senior faculty, and always been present and blessing us for all the activities and guiding us timely, giving us very important messages whenever it is necessary. Sir is the patron of KSOGA, former president of KSOGA, has been the EC member of KSOGA, is the charter member of KSOGA in 1986, and that speaks the volume of knowledge he has about the finer nitty-gritties of the KSOGA and the bylaws. And he has organized the KSOGA State Conference in 2005 and 2017 two times, former president of IMA Shumoga, 1991, charter member of the Malnad Institute of Oncology, charter member of Sushruta, Biomedical Waste Management Shumoga and Vice President, and Charter Member Malnad High-Tech Diagnostic Center Shumoga. His areas of interest have been high-risk pregnancy and adolescent health issues. And even today, he continues to be very active participant of all the webinars or scientific meetings. And it was amazing to see him sitting all the 3 days through in the Bijapur conference, which was held recently, and giving his valuable contribution. Hearty welcome to you, sir. And please grace the occasion. Thank you.
Ma'am, please do introduce Madhuri Patel, ma'am, too, ma'am.
All right. So,
hello, let Sir speak. Sir has been introduced. Let Sir speak. Sir,
Sir. Nagraj sir, please say a few words.
Very good evening to all. I would like to thank the organizers for having the opportunity of participate in the Gyaan Sangam. That is acquiring of the Gyaan. But I am Agnani. Many are here. I would like to congratulate the organizing this event. And also I would like to wish all happy International Women's Day in advance.
Thank you, sir.
This month we are celebrating International Women's Day. Dear Chief Guest, beloved Dr. Rishikesh Pai, immediate past president, ever charming. He has unique distinction of serving the Foxy as president following his wife, and both have served the Foxy as presidents. Another couple is Dr. Malhotra couple from Agra. They have served, both are as the president of Foxy. Madhuri Patel is our guest of honor. I met her in Bijapur. She is a very dynamic Secretary General of Foxy. I am sure in days to come, she will occupy the chair of Foxy President.
Yeah.
Dr. Bharati Rashekar, our President-elect, and she is going to be installed as a President in Manipal in the month of April. She is ever enthusiastic. I wish her a fruitful year, and we are awaiting to see that she starts her tenure in April. Dr. Vidya
Thank you,
Tobi
sir. Thank you,
is
sir.
a professor in Bijapur College and our president now. She has done a lot of good work in KSOGA and brought many committees into a single fold, and she has done a marvelous work in this program. Rajashree Palladi, our dynamic secretary, whenever I asked her to contact her, she has responded well and she has taken the words and she has implemented many programs, and I wish her to become the
Thank you.
president of KSOGA.
Thank you, sir.
Our chairpersons Sunita Wadmani and Dr. Shailesh P. They are very dynamic academicians and they are chairing the sessions. And our panelists are going to enlighten us on the aspect of preterm labor and first trimester anomalies and adolescent endometriosis. I wish the deliberations all success. Thank you, one and all, and I wish the program a fruitful one for all the participants. Long live KSOGA and Foxy.
Thank you so much, sir. Thank you for your words of wisdom.
Thank you, Rajeshri Madam, for introducing the chief guest and the guest of honor. Now we get into our first session, which are two talks by one.
Shobha,
No,
Dr. Madhuri Patel needs to be.
Madhuri Patel, please.
Yeah.
Please introduce Madam as the guest of honor.
Rajeshri Madam will introduce our guest of honor, Dr. Madhuri Patel.
Dr. Madhuri Madam, true to her name, is so Madhu, full of sweetness, that we have seen and witnessed her simplicity and sweetness for all the programs, especially the KSOGA, wherein she graced so well and been very, very cordial with all of us. And we felt very happy to have her with us in KSOGA, Bijapur. Thanks to Vidya Tubi ma'am. And Arun, are you putting on this? Yeah. So, Secretary General of Foxy, Dr. Madhuri A. Patel, ma'am, is the editor-in-chief of JOGI, that is the Journal of Obstetrics and Gynecology of India, Joint Secretary of Foxy in 2009, the first Secretary General of Foxy, in fact, and committee member of FIGO Preterm Birth, Honorary Secretary Associate of Wadia Hospital, Parel, Mumbai.
Thank you, Rajeshri. Thank you, Rajeshri.
And so many more that it is lovely to read the CV, madam, because the delegates should know what are the personalities we have leading our esteemed organization, so that it becomes an inspiration for everybody to emulate. So let me read She's received the Appreciation Award in 2021 by ICOG, awarded the Moggs Ganatra Charitable Medical Center Award, Social Issues on Women's Health for the year 2022-23, delivered guest lectures at national and international levels, and many conferences and more than 50 publications to her credit, and written many books, chapters in the books. Welcome to you, ma'am.
Thank you, Dr. Rajeshri. Yeah, thank you so much for your warm and generous words. And I really appreciate all of you to, say so many warm and generous words. So I'm really, overwhelmed. So respected our chief guest today is Dr. Rishikesh Pai, my dear friend. And I had opportunity to work with him since last 3 decades. And last year I was Secretary General and he was President. We had a vibrant year. Of course, during Shanta Kumari time and Jaideep time also we are having both the same, but with Rishikesh we moved around in the yatra at so many places, and he is really, he is very innovative. What he thinks he implements. Then we have Dr. Nagaraj, who is today's guest of honor and patron. Sir, I am really thankful to you for showering your blessing to me for my future endeavors. Then Dr. Hiramat sir, he is I had taken over in Foxy as from him the brace committee chair, and he's my mentor with Dr. C.N. Purandaresa. So I respect him a lot. Then, of course, our president, KSOGA, Dr. Vidya Tobi, my very, very dear friend, and we are sharing so many things. And now also, when I came to Bijapur, Rajashri, Vidya, and all the Bijapur, team has taken so much of care of me that I cannot forget, everything, they have done from A to Z. I remember that I had to rush to other place on Saturday. So we made it Friday, but still they were very, very generous to accept that I'm coming on Friday and not on Saturday, Sunday. So I already committed to Rajana Allahabad, she was having conference. I said, Vidya, I also committed. So I'll come over there. So it was very nice to be there in Bijapur with the great academics and the great, everything was great over there. Then, of course, we have our president-elect, Dr. Bharti Rajshekhar, very, very active and dynamic. And I'm sure she will also do the great work. And our another Dr. Durga Das, president-elect. So I met him not only in Hyderabad but at Bijapur also. He will also take it forward to the greater height. Then Secretary Dr. Rajeshri Paladi, you have heard her, and she is also a great lady, and I wish her best for her president post. Dr. Treasurer Dr. Suman, convener Dr. Rashna, coordinator Dr. Shobha. Then our chairperson Sunita Wadhwani from President Ratnam Society, Dr. Saijers, chairperson Midlife Management Committee Foxy, Dr. Bela Bhatt, our Imaging Science Committee, Dr. Anu Chawla, who is the Endometriosis Committee of Foxy, Dr. Parag Binewala, again my great friend, Dr. Rosa Olai, I know her since so many years, and we would have worked together. When I was joint secretary, she was a vice president, and before that, she was adolescent, chair. And she has done great work. She has taken this to Figo. She has done so much of great work. So I'm really, really happy, and say that she is my great friend. And of course, we have Dr. Sneha, very hardworking, very much dedicated. Then we have Udayan sir, Sarkar sir. I'm going to go now in this weekend over there. Dr. Gitanjali, Ludhiana, they have done a great zonal conference. Then we have Dr. Bhanu Sri Lakshmi. And I can see two Bhanu Sri Lakshmi, but photos are different. So I was a little confused in the brochure. And Dr. Bimba, Dr. Mahesh Koregaon, and all my dear friends. Very good evening to all of you. I consider KSOGA also as a part of our family of Foxy. We are not different because our missions are same, right? And we are working for women's health. So I'm really privileged, to be here for the KSOGA Gyaan Sangam wellness, for women, or 6 episodes. I'm really privileged to give my message on this platform. And I must only say that we all are working towards women's health, and we should continue working towards women's health. Then your topics are very important. Vidya is talking on prevention, because we know every year 15 million babies are born preterm, and 3.6 million itself from the India are born. And the majority of the baby, there is a high perinatal mortality, and the children die before the age of 5, majority of them because of the preterm. So prevention will definitely reduce this preterm birth. Then, of course, the other topic is, what Dr. Bela is going to speak is first trimester anomaly. And I know that we always used to wait for second trimester anomaly scan, 18, 19 weeks, 20 weeks, and your MTP law is to say you can't do now. But now the MTP amendment has come up to 24 weeks. But the first trimester, knowing the majority of anomaly is so important that if the life is not compatible with the life, the fetus is not compatible, we can terminate, and it becomes an easy termination in the first trimester. So Bela is a great orator, Vidya is a great orator, and of course, Dr. Bharti is going to moderate a panel on adolescent endometriosis. Whenever the patient come to adolescent patients with, severe dysmenorrhea, we consider, yes, this is a spasmodic pain. And we always feel that is a physiological, thing is happening. But nowadays, the age of, everybody is career oriented, they're educated, so the marriage is late. In the past, 17, 18 years old girl used to become pregnant, so there was no endometriosis. But now we are seeing lots many endometriosis in adolescents, and we have to take care, because these adolescents are considered without disease. They are neither coming in the children, neither or either coming in the adult. So we just try to ignore them, because they have less health problem, but they have many, many problems: menstrual problem, mental problem, drug addiction, and this. So we have to take really care of this. And this endometriosis in adolescent is diagnosed very late, because we just ignore them. So these are very excellent topic, and we are really happy that we have to have wellness of women. And I congratulate all of you for the same, and wish you best for your future endeavor. Thank you once again for giving me this opportunity.
Thank you, madam. Thank you,
Thank
Dr.
you, ma'am.
Thank you, Rajeshri Madam, for introducing the chief guest and the guest of honor. Now, after taking blessings from all the stalwarts of KSOGA and Foxy, now is the time to start the session 1. Now I call upon our EC, Dr. Mahesh Koregal, sir, to introduce the chairpersons for session 1. Sir, please. Arun, please share the CVs of chairpersons.
Thank you, Dr. Shobha, for the opportunity. And at the outset, I would like to invite our senior, Dr. Sunita Wadhwani, madam, who is the president of Ratlam Obstetrics and Gynec Society. She is the director and consultant of Ratlam Hospital and Research Center. She is NABH assessor, and she has done her MBA in hospital and healthcare, and a special interest with the critical obstetrics. And madam is a lead assessor and master trainer in Manyata by Foxy. Madam has many feathers in her cap. And madam, we are happy to have you as chairperson, and we welcome you.
Thank you very much, Dr. Mahesh. Yeah. Thank
And
you very much.
next, I will be happy to introduce my friend who is not less than Amitabh Bachchan or Amir Khan of Bollywood, or Mammootty of Mollywood. He is Shaijus, who is a versatile actor and a very good singer, and also he is a dancer. If any of you happen to follow his Facebook, you will know how talented he is. You will not even realize that he is a doctor himself. So Shaijus is one of the most multi-talented doctors I've ever seen, and a good friend of mine. And he's a very motivational speaker also. And a good number of videos he uploads about his dances and singing songs, and you really enjoy it. Recently, when Pankaj Udas passed away, he uploaded one of the songs. You should all listen to it. He is the chairperson of the Midlife Management Committee of Foxy till 24. He was a past president of Kannur Obese Society. He is an IVF consultant at ARMC IVF Fertility Center, Kannur. And he has many awards and accolades. S.N. Joshi Women Empowerment Award of 22, Mrs. Shailaja Pandit Women Award of 20, and MS Signature Social Reformer Award of 22, Dira Award of 22, Foxy International Traveling Fellowship Award for 2019, Foxy Superstar Award of 2019, Dr. Kamini Rao Orator, Dr. D.K. Tank Report to Healthcare Trophy as President, Dr. Sadhana Desai Population Stabilization Prize in 21-22, Dr. Durusha Yuva Trophy in 2019 and 2020, Dr. Chaitara Preventive Oncology Award, and Smriti Mailan Award, and Foxy Future Award in 2017, and Foxy Talent Award 2017 South Zone. So, Dr. Shaijus, we are more than happy to have you here with us, and we welcome you.
Dr. Shaijus is busy in the OT, so I think Dr. Sunita Wadhwani can take the session forward.
In the meanwhile, I will be sharing my screen.
Now, Dr. Sunita will introduce you, Dr. Vidya. Let her introduce the subject.
No
Dr. Sunita, madam, please.
Yeah. A very good evening to each and everyone. It is such a great pleasure to be sharing this platform with so big and great dignitaries from Foxy. I welcome Dr. Rishikesh Pai sir, Dr. Madhuri Patel ma'am, Dr. Nagarajan, and it is my privilege to be part of this platform. I would like to introduce Dr. Vidya Thobi ma'am. She's President KSOGA 2023. She is chairperson of Food, Drug and Medical Surgical Equipment Committee, FOXY, from 2018 to 20. She has got Best Committee FOXY Award, Dr. Mehru Daransotia, 2020. ICOG Governing Council Member, 23-25. She's FOXY Champion. She has a FOXY Champion Award, 2019, and many more awards to her credit. She is National Corresponding Editor of Jogi, Organizing Chairperson KSOGA 2023, President Bijapur Obsgyne Society 2009, Secretary Bijapur Obsgyne Society 2007, publication in various books and contributor to FOXY Focus and speaker at national and international conferences. She has many papers at national and international conferences to her credit. She's organized various CME workshops, awareness programs in under FOXY platform. She has been advisory faculty of board Rajiv Gandhi University of Health Science and postgraduate and undergraduate teacher for 30 years. It was my privilege to be introducing such a great speaker. Welcome, Dr. Vidya.
Thank you, Dr. Sunita. And I'll just share my screen, and I just want to thank actually my own KSOGA family for bringing me here. And I have just chosen this topic. I have not included the management or the prevention much, but I just wanted to have about something about the prediction. So the prediction is very important for the preterm labor, as we all know that the incidence of preterm labor is increasing. So my postgraduates, many of them, they have joined. So I start with the definition and terminology. The preterm labor, we all know that it is the onset of uterine contractions, and these contractions should be of adequate strength and frequency to cause progressive dilatation and effacement of cervix. That is cutoff we tell as 37 weeks. Of course, it goes on changing. The lower limit is very controversial. It can be 20 weeks up to 27 weeks. And as we all know, the salvageability of changes depending on your NICU care. Now, various definition again change. That is, we call it as a threatened preterm labor when there are uterine contractions without any cervical dilatation. Diagnosed preterm labor, there are cervical changes with the uterine contractions. And when the established preterm labor, when there is a contractions plus progressive cervical dilatation more than 4 centimeters. So there is a working classification as well, where we divide preterm labor into extreme preterm, that is less than 28 weeks, early preterm between 28 to 32 weeks, and late preterm from 32 to 37 weeks. And majority of the preterm labor, they belong to the late preterm. Please mute everyone. Preterm birth magnitude is it occurs in 7 to 12% of all deliveries, and in India it is around 23.3%. So over 35 lakh annual preterm births occur in India, and it is the highest incidence if you see the country wise in the world. India tops the list, and it contributes to the 60% of the world's preterm birth. And this is the magnitude. And what has caused is it is the biggest cause of neonatal morbidity and mortality, accounts for 2/3 of the neonatal deaths, and it affects to the 23% of the pregnancies. So one of 5 P syndromes, what we call it as a preterm, premature, PPROM, PIH, that is hypertensive disorders in pregnancy, and PPH. So 70% of the neonatal deaths, 36% of the infant deaths, 25 to 50% of the cases of long-term neurological impairment of children because of preterm delivery occurs. And this is a leading cause of perinatal mortality. So rising rate, it is a concern for us. So there is increased frequency of multiple births due to artificial reproductive techniques, young or advanced maternal age, low BMI, short inter-pregnancy intervals, pre-existing non-communicable diseases, infections, and increasing physical and psychological stress, which takes a major chunk of our day-to-day life, iatrogenic preterm birth between 35 to 37 weeks, and these are the various causes of iatrogenic preterm birth, like preeclampsia, fetal distress, small for gestational age, placental abruption, placenta previa, gestational diabetes, renal disease, Rh isoimmunization, congenital malformation, unexplained bleeding, as well as various chronic hypertensive diseases. So these are the various challenges when we come to the diagnosis of preterm labor. The risk factor are not reliable indicators, as 2/3 of the patient with the risk factor do not deliver preterm. Half of the patient who deliver preterm have no risk factors. If you are evaluating whether these methods are underused, normal cervical length with negative rapid fibrinolactin, 98% deliver at more than 35 weeks, 35 and equal to 35 weeks. Short cervical length with positive rapid fetal fibronectin, 50% deliver at 37 weeks. So are they the standardized protocol are lacking? Standardization will allow timely intervention and transport to the higher level for fetal acuity, avoid unnecessary antenatal treatment. So vague symptoms, we over treat the patient, and sometimes these symptoms are neglected and patient lands with the preterm labor. These are also things going on. So prediction of preterm labor, what are the patients at risk? So there are various scoring systems which are based on the risk factors and obstetric history, and only about 30% of the preterm birth are predicted correctly. The low specificity makes it very difficult to base intervention on these scores. So there are various scoring systems available. The current useful predictors are previous history of preterm delivery and other risk factors. Second one, we always rely on transvaginal cervical ultrasound, biochemical, fetal fibronectin, and salivary estrol. So these are the main, if you remember this picture, you can just think of various causes of preterm labor: uterine overdistension by any cause, decline in progesterone action, cervical disease, breakdown of maternal fetal tolerance, stress. There are unknown factors, infection, vascular disorder, decidual, all these factors, they come into action in the etiology of preterm labor. So this is in general the various causes. I'll not go into the details because we repeatedly we talk on these, and most importantly, the history of preterm birth is most common cause of preterm birth, and mostly the shortening of the cervical length by any means. There are sometimes intraamniotic infection which lead to uterine contraction, leads to shortening of the cervical length. Here, just I have divided the same, these are the causes I have divided into for remembering. There are maternal causes, they are systemic maternal medical illnesses like heart disease, hypertension, anemia, non-obstetric abdominal pathology as well. The infections like bacterial vaginosis, drug abuse or trauma, uterine causes like malformation, acute overdistensions, various uterine anomalies, especially additionally any hydramnios, there is a overdistension, and placental causes like placental abruption, previa and placental bleeding. Fetal causes, fetal malformation, multifetal gestations, fetal hydros, fetal distress, fetal growth restriction. Then amniotic fluid causes polyhydramnios, even oligohydramnios, PPAROM, infection, clinical chorioamnionitis. Subclinical, it is very difficult to judge unless you do the amniocentesis. Cervical causes, cervical incompetence, conization, and loop resection. The various risk factors again are divided into non-modifiable risk factor and modifiable risk factor. Let us concentrate something about the modifiable risk factor. Something about the smoking and illicit drug use, they are also blamed. Anemia and mostly the infections like bacteriuria, asymptomatic bacteriuria, urinary tract infections, gingival disease. We never open the patient's mouth and see any caries tooth or gingival diseases is again a cause as a focus of infection in preterm labor. Strenuous work or work environment, which causes stress, and lower genital tract infections and stress, and strenuous exercise. These are the modifiable risk factors which we can of course can address. And of course, in the non-modifiable, definitely the poor nutrition also can be addressed, and sometimes we can reduce multiple pregnancy in this one ART. They have now some rules and regulations for the transferring of the embryos, not more than 2 or 1, like that. So risk factors, KSOGA says that short cervical length and prior preterm birth. These are the 2, and plus a history of cervical surgery, uterine instrumentation, repeated dilatation, and other factors like, again, vaginal bleeding, UTI, and any focus of infection and behavioral risk. Now, this is a score which commonly is addressed to, that is Papernik's score, which is modified by Gonick and Creasy. And they have divided this risk factor and they have given some these numbers like 0 to 5 low risk, 5 to 9 medium risk, and more than 10 and equivalent is a high risk. So here is the Indian study, and there are many studies which are available. They have done this study, that is a development of risk scoring scale tool for the prediction of preterm birth. So it is a community-based study which is done in our own Karad, which is very nearer to Bijapur. They have done that community-based study to test the feasibility and the acceptability of these risk predictors of preterm birth. By just they have developed some testing and scoring system which are done. And what they have found is the community-based study to test this feasibility or acceptability, by whatever they have developed the scoring system as Papernik has done, they are required according to that place, means what are the means infections are common and all. They have given more scoring to those factors, and they have done found out that this effective or feasible and acceptable scoring system should be developed according to the region and the priority. So that can be incorporated in routine ANC services. So in your antenatal care, whether this patient is having any predictability of the preterm labor, just you have to put it as a right or wrong. So this identification is very important for the delivering preterm baby. That will improve the outcome also. There are so many predictive models. This is a Korean model, and this is called as a Copian. They have done the registry linked database cohort studies. So this is called as Copian registry linked database. So who is at risk of preterm labor? They say that history of prior preterm birth, less means decreased cervical length, that is shortening of the cervix, less than 25 millimeters, symptoms of preterm labor, which are very unpredictable, and increased fetal fibronectin. So screening should be done. One is history, whether the risk factors are modifiable or non-modifiable. Second one is cervical length, ultrasonography for the cervical length. Per speculum examination, and that is a vaginal examination. Of course, PV is not indicated, but at least speculum examination. Screening for vaginal infections and bacterial vaginosis, and the biochemical markers in the cervico-vaginal secretions like fetal fibronectin testing, placental alpha macroglobulin, insulin-like growth factor binding protein. These are the various biochemical markers which are studied. Now, what about cervical length? Cervical length is most commonly we do. And the rationale is cervical length is cervix is a dynamic structure. It physiologically shortens with increasing gestation. And this cervical shortening is one of the first steps in the process leading to the labor. Can precede labor by weeks. So effacement begins at the internal os and progresses caudally. So mean cervical length in pregnancy is at 11 to 14 weeks is around 42, and 22 to 24 weeks it's 38. So to assess the risk of preterm labor, to distinguish between the true and false spontaneous preterm and in-threatened preterm labor. Then it is very important to how to measure cervical length. It requires expertise. So it is a reproducible measurement from 14 weeks and consistently possible from 16 weeks. It is stable between 14 to 24 weeks. We have Dr. Bela Bhatt with us, and anyway, she is talking to us in first trimester anomaly. She has to say a few words about this also. I expect from her. So digital examination, of course, earlier when the sonography was not available, they used to do digital examination serially, and they used to tell that it is a shortened or it is very cervix is short. But there is always a inter-observer variability. Trans-abdominal sonography, transvaginal sonography, transperineal ultrasonography. Now, this is one instrument to decrease the inter-observer, this one observational variability. They have found this cervical length, by which you can just measure the cervical length. Just put the flange here and measure the cervix from the fornix. And they used to measure every week for the, just find out the cervical length. Now, what is the disadvantage of trans-abdominal sonography? The patient's bladder must be full to assess the cervix inadequately, but this may spuriously lengthen the cervix by opposing the anterior and posterior lower uterine segments and concealing the cervical shortening or funneling. Transvaginal ultrasound is performed with bladder empty, and visualization of the cervix is hampered significantly by one is maternal obesity, shadowing from the fetal part, and need for the lower frequency transducers. So transvaginal sonography, we all know it is a gold standard. You have to empty the bladder, dorsal lithotomy position, probe should be directed in the anterior fornix. It should acquire the sagittal long axis image of entire cervix. So 75% of the screen should show this. And avoid excessive pressure on the cervix, the cervical canal, whether there is increase or decrease echogenicity, and surrounding cervical mucosa need to be identified. Now, normal cervix looks like this, and the ultrasound of normal cervix with equal thickness of anterior and posterior cervical lips. You can see here the cross marks the internal cervical os, plus marks the external cervical os, and the echo-dense line connecting the 2 points is the endocervical canal. Now, calipers are used to measure the linear distance between these triangular area of echo density at external os and V-shaped notch at internal os. The shortest of the three measurements are taken as cervical length, and the dynamic cervical shortening by putting the suprapubic or fundal pressure. Now, this is a measurement. We have to find out the actual cervical measurement, as you can see from the picture, is the B. So funnel length should not be measured or recorded as it is not an independent predictor of preterm labor risk when the closed length of the cervical canal is considered. So you can see here B is the cervical length and the A is the funnel length. The short cervix occurs in second trimester is a strong predictor of subsequent preterm labor in 92% of specificity. And we can see that 25 millimeters before 24 weeks is a 10th centile. So 25 millimeter is taken as the diagnostic threshold, and there is a meta-analysis of various RCTs of therapeutic interventions. So they say that if you take 25 millimeters of cutoff, there is a 30 to 40% reduction in bleeding. So you can see the various pictures of the cervical length measurement. So diagram, we know that T, Y, D, and U, and the progression of cervical effacement at the internal cervical os from completely uneffaced to completely effaced, that is U. So funneling occurs, dilatation of the internal os observed sonographically as funneling. As cervix effaces, as we tell that it is the relation between the lower uterine segment and cervical canal changes according to the shape of letters T, Y, and E. Significance of short cervical length. A decrease of cervical length to less than 25 millimeters before 24 weeks is a predictive of spontaneous preterm birth, and this risk increases as cervical length decreases. By contrast, a gradual decline in the cervical length after 32 weeks can be normal or not predictive of spontaneous preterm birth. So, less than we have to take at the proper gestation. What ACOG says that in practice bulletin on preterm birth, ACOG concludes that The cervical length screening with serial transvaginal sonography is indicated in a singleton pregnancies where there is a history of prior preterm birth. So in the patient where there is a spontaneous preterm birth in early, so you have to take a serial measurement. And when there is an absence of this spontaneous preterm birth, ACOG recommends the imaging of cervix with either transabdominal or transvaginal approach at 18 to 22 weeks of gestation fetal anatomy scan. So what does the FIGO says? The FIGO recommends sonographic cervical length screening of all patients with singleton pregnancy at 19 to 23 plus 6 weeks of gestation using 23 plus 6 days, weeks of gestation using transvaginal sonography. So is there any role of universal screening? It is based on the evidence from several studies. For example, large observational study of introduction of universal cervical length screening in singleton gestation without prior spontaneous preterm birth was associated with significant reduction in the frequency of spontaneous preterm birth compared with the period before screening was implemented. So they say that universal screening should be recommended. So there are various recommendations by various bodies. So FIGO does recommend cervical length measurement in low risk population, and it should be performed. Again, I have already told that it is 19 to 23 plus 6 days of gestation using transvaginal sonography. Can be done in the same sitting when we are doing anomaly scan. And of course, the Canadian this OBGYN society, they say that it cannot be mandated at this time and more research is warranted. High-risk women, you have to do every 1 to 2 weeks, depending on the clinical status between 16 to 24 weeks, and the serial screening is more effective. So there should be a screening protocol for the prior twin spontaneous late preterm birth, screen for the short cervix with single examination, transvaginal of course, approximately at 20 weeks, as in singleton pregnancies with no prior preterm birth. Prior twin spontaneous early preterm birth, less than 34 weeks, transvaginal ultrasound cervical length screening at 14 to 16 weeks of gestation. The earlier the prior spontaneous preterm birth, the earlier should be the screening. And perform serial examinations as in singleton pregnancies with prior preterm birth. So if there is a prior preterm birth, we should be vigilant and do the screening program, screening the weekly basis. Now, this is a general approach of transvaginal sonography in patients in the singleton pregnancy and the management of the pregnant people with the short cervix. When and how often should be cervical length measured? That is a question. And singleton pregnancy with no prior spontaneous singleton preterm birth or twin gestation, you have to do single transvaginal sonography at approximately 20 weeks of gestation, that is between 18 to 24 weeks. If cervical length is more than 25 millimeters, you have to do the routine prenatal care. If it is no, then you have to prescribe vaginal progesterone suppository daily throughout till 36 weeks of gestation. If cervical length is less than 15 millimeter or becomes 15 millimeters on progesterone therapy even, then you have to consider the placement of a cerclage. If it is a singleton pregnancy, previous spontaneous singleton preterm birth at 14 to 27 weeks of gestation, that means early preterm birth, you have to do transvaginal sonography at 14 weeks of gestation. And then if the cervical length is more than 30 millimeters, then repeat measurement every 2 weeks through 24 weeks as long as cervical length remains at 30 millimeters. If it is no, then cervical length, if it remains at 26 to 29 millimeters, repeat measurement weekly to 24 weeks as long as the measurement remains the same. If it decreases to less than 25 millimeters, you have to again place the cerclage. Whereas when there is a singleton pregnancy with previous spontaneous singleton pregnancy, preterm birth at 28 to 36 weeks, that is a late preterm birth, you have to do transvaginal sonography at 16 weeks of gestation and follow the same protocol. So here you have to do the main focus is on ultrasonography and the measurement of cervical length. The second is a biochemical marker, which is very costly and routinely we don't do, but we should know about it. Fibronectin is a protein that binds a fetal membrane to the deciduum, and we call it as a biological glue. And it is normally found in cervicovaginal discharge before 22 weeks and again after 37 weeks. Hence, it is normally present at the 20 to 22 weeks, it is present. Around 22 weeks, the chorion completely fuses with the underlying decidua, which prevents any fibronectin to leak into the vaginal secretion until term. What happens in the term? When the cervix dilates or membranes rupture, it is again present in the cervicovaginal secretions. So if it is found that it is more than 50 nanogram per ml, it is positive, and chances of preterm labor are 35% higher. High negative, it has got a high negative predictive value. Remember this. More than 99% of symptomatic patients with negative fetal fibronectin did not deliver within 14 days. Owing to high negative predictive value of fetal fibronectin, negative fetal fibronectin value is helpful in reducing unnecessary patient interventions and management protocol. That is what it is the importance of fetal fibronectin. So indication is symptomatic preterm labor between 24 to 36 weeks and intact membranes. The contraindication, ruptured membranes, if there is a vaginal bleeding, cervical cerclage is there in situ, after the use of lubricants or disinfectants, and within 24 hours of coitus or vaginal examination. You cannot do this. If the test is negative, the risk of preterm labor is less than 1% within 14 weeks, 14 days of test. Hence, useful to exclude diagnosis of preterm labor. Swabs can be taken from the ectocervix or posterior vaginal fornix for fetal fibronectin testing. And digital examination of the cervix or lubricating gel must be avoided. In women with threatened preterm labor, NICE guidelines says it recommends this fetal fibronectin testing for women more than 30 weeks and if transvaginal sonography is not feasible again. So fetal fibronectin, what is the sensitivity? It is 58 to 0.8% sensitive and 78.8 specific. So ambulatory uterine monitoring, which we used to do earlier, and there are many studies in the books about the ambulatory uterine monitoring, home uterine monitoring, that does not predict preterm birth. Also this I want to tell is about the asymptomatic high-risk pregnant woman. Also that can be useful test. They have done some algorithm which has got a combining this quantitative fetal fibronectin and cervical length. Both they have combined and they have done the demographic information and the obstetric history. Whether the patient has previous spontaneous preterm birth or PPROM or current suspected preterm labor. And that they have incorporated again app. We are very much app friendly. So they have labeled this app as a QUIP for the prediction of spontaneous preterm labor in Europe. And they have done so many multicentric trials which involved 1,900 pregnant women between 23 to 34 34 weeks plus 6 days with symptoms of preterm labor. The QUIP app did not reduce any unnecessary treatments compared to routine management. So they have done this app and have incorporated all the data. So threatened preterm labor, cervical length in conjunction with both they have done fetal fibronectin. If fetal fibronectin is negative, no treatment. And if it is positive, they have given corticosteroids and other interventions. Now this is a test which is called as pre-TRM test for two serum proteins, that is insulin-like growth factor binding protein 4 and sex hormone binding globulin, which is available for clinical use for prediction of preterm birth. So in a study to develop and validate a mass spectrometry-based serum test to predict spontaneous preterm birth in asymptomatic pregnant people, the test had sensitivity and specificity of 0.75 and 0.74 respectively. For prediction of preterm birth less than 37 weeks, screening has to be adequately tested and validated. There are various other biomarkers. There are over 30 biomarkers which have been studied for identification of these asymptomatic pregnant people at high risk of preterm birth. And they have done systematic reviews of these biomarkers, including 72 observational studies involving about 90,000 participants, and concluded that none of these biomarkers alone or in combination was clinically useful for prediction of spontaneous preterm birth in asymptomatic people. The marker included inflammation-related biomarkers, placental protein and hormone-related biomarkers, angiogenesis-related biomarkers, coagulation-related biomarkers, genetic biomarkers, which are upcoming now, proteomic-related biomarkers, and markers of dysfunctional vaginal microbiomes. So these are various biomarkers which have been studied, and research is going on, and we always talk of evidence-based practice in medicine. So keep following research and changing guidelines and international bodies. Now, use of RNA profiling either in the maternal circulation or in the cervix is a promising area of active investigations. Additional studies are needed to characterize the specific RNA species and identities of these most predictive markers, and then to test them in well-designed prospective studies in both high and average risk population. So these are the various studies which they have published, and what they say as genomic, proteomic, metabolic approaches will ultimately enable the discovery of novel molecular biomarkers which are involved in the physiology of labor. First of all, we have to understand what is the physiology, then we can understand the pathology of labor. So pathophysiology of preterm birth is very complex, and it is becoming increasingly evident that various groups, means biomarkers are plenty, more than 70, 90 they have been discussed. So how much to give importance and what are the risk factors, cervical length, molecular biomarkers, they may be required for this distinguishing various pregnancies, experiencing the spontaneous preterm labor, spontaneous preterm PROM, and symptomatic preterm labor, whether these are in the presence or absence of genital tract infections. So again, we have to screen the genital tract infections also, the urinary tract infection. If the infection, we are questioning that it is a cause of the preterm labor. So these are the just a chart. I am not going to discuss all. Might be in my next lecture, I will talk on interventions and prevention of preterm labor by various interventions. So these are the various interventions which we can do for the prevention of preterm labor. First is prediction, then intervention. So I just want to say that there are n number of causes and n number of interventions. The clinical usefulness for this, I have already talked about this copain cohort study, so I will just end my talk that n number of studies, n number of things, and n number of interventions for prediction of preterm labor. So I am very much thankful. I'm there till the end of this session. I'm very much thankful for my KSOGA family. I also declare my candidature for the Vice President for the South Zone. And I request those who have joined for nominating me from their societies. I also welcome all the people, all the delegates who have joined across the whole India, those who have joined. Those who have joined, though only 41 people might be, but they have come from various states. So thank you very much again. Thank you, Chairperson Dr. Sunita. I think Dr. Chaizus, so he could not join. So thank you very much again. So I'm stopping. I'll stop sharing my screen. Thank you very much.
Dr. Sunita, madam.
Sorry, I was not able. Yeah. Excellent presentation, Dr. Thobi, ma'am. It's always a pleasure listening to you on various topics. And you very beautifully described all the risk factors and particularly elaborated on cervical length, the fetal markers, and various other biomarkers. It was definitely a learning experience for all of us, a very important and a very regular topic which we deal in our day-to-day life. Thank you very much.
Thank you very much. Thank you.
For this next session, Am I supposed to introduce Dr. Bela or?
Yes, madam.
Yes, ma'am.
You're
Yes,
supposed
Yeah,
to.
yeah, yeah.
Okay,
Yes, ma'am.
okay. So for the next topic for today is the first trimester anomaly scan, which teacher of teachers in ultrasonography, Dr. Bela ma'am is going to be taking. Can I have the CV, please?
Madam. Arun, please share.
Arunji, can I have the CV? Yeah. It is not a very, I mean, I always feel Dr. Bela, but ma'am doesn't require an introduction, but still to finish off with the formalities, I'd like to introduce her. Dr. Bela Bhatt ma'am, she's chairperson Foxy Imaging Science Committee. She's a lead consultant of Dr. Bela's Women Hospital and Fetal Medicine Center at Andheri, Mumbai. Fetal medicine consultant, Dr. Babasaheb Ambedkar Memorial Central Railway Hospital, Mumbai. FMC UK certified sonologist for fetal abnormalities. FMF certified sonologist for nuptial scan. Foxy certified trainer for ultrasonography in obstetric and gynecology. Author of the book, The Vital Skill, Ultrasonography in Ultrasound in Obs and Gynae. She's Joint Secretary, Association of Fellow Gynecologists, Mumbai. She's Managing Council Member, ISPR, Life Member, SFM. She has done first prize at AICOG 2019 Bhubaneswar, winner of Foxy has Talent National Competition, National Convener for Foxy Superstyle Competition, National Talent Coordinator Foxy has Talent, one PCPNDT case in Bombay High Court by fighting it in person. Welcome, Dr. Bela, and we are waiting to be listening to your very favorite topic, first trimester anomaly scan.
Thank you so much, Dr. Sunita, for those kind words. I'll just take a couple of seconds to share my screen. Just give me screen. This is okay. I'll just take this. Yeah. You can all see my screen.
Yes, ma'am.
So at the outset, first of all, I would like to thank KSOGA family, especially Dr. Vidya Thobi and Dr. Bharti for giving me this opportunity to be part of this wonderful webinar. And also when we have started this webinar with blessings of dignitaries like Dr. Rishikesh Pai and Dr. Madhuri Patel, this indeed is going to be a successful webinar. I also see a lot of friends here, Dr. Rosa, Dr. Neha, and many more, Dr. Shobha, Dr. Sunita, Dr. Mahesh, and many more from KSOGA family. So it's really indeed a pleasure to be giving this talk on first trimester anomaly scan here. Entire fetal medicine is very, very close to my heart. And again, first trimester anomaly scan indeed is very close to my heart. Now, traditionally, we had been looking at the fetal. Can we mute all?
Arunji, can you please mute?
So traditionally,
please mute non-speakers.
So traditionally, we have been looking at fetal anomaly at 18 to 20 weeks or 18 to 22 weeks anomaly scan. That's a second trimester anomaly scan. But now we know that we have moved to our early anomaly scan, that is 12 to 14 weeks scan. And what are the various dimensions of this scan that we are going to go look at in my talk? Now, as we know, there are three main objectives of doing nuchal scan or this 11 to 13 week 6-day scan. Number one is risk calculation for trisomies. The other one is anomaly detection, and the third is risk calculation for early preeclampsia. But each arm of this needs a lot of time to discuss. So I'll just concentrate on anomaly detection. We know that in past 2 decades, 2 to 3 decades, because of improvement in the skill of ultrasound and because of higher-end machines and resolutions, we can pick up almost 50 to 60% anomalies right at first trimester or right at third month.
there are various anomalies picked up at my center between 11 to 13 weeks scan, but I'll just tell you there are always detectable 9 anomalies which should never be missed. Rather than listing them up, I think I should go on to show you various basics of how to pick them up, and I'll also show you some of the anomalies. So what is the basic concept to pick up these anomalies? We all know that to pick up any abnormality, we must first know as to what is normal. So we must have idea as to what structure normally it looks on ultrasound when we do a nuchal scan. So typically when we start a nuchal scan, it starts with viability. Yes, we also want to be sure that the baby is viable. Patient also would like to see that the baby is having a cardiac activity. So first thing first. Second thing, as even for aneuploidy, we need a crown rump length. A good crown rump length in a standard manner has to be taken by a trained sonologist, and then only this CRL is valid and not otherwise. So we know that the baby has to be in neutral position, mid-set section. The crown and the rump both should be seen clearly, and the fetus should be occupying at least 75 to 80% of the screen, and then the CRL is considered valid. This is also extremely important for dating of pregnancy, because based on this we'll be able to monitor the growth of the fetus. Now when we look at this initially we initiate this scan, we do a sagittal axial sweep. These sweeps themselves can give us a lot of information. So sagittal sweep is going to show us various structures and the axial sweep as well. So what all structures we'll see in the sagittal? We'll see both upper and lower limbs. We'll see the diaphragm. We'll see the stomach. We'll see the bladder. We'll see the intestine. And of course, the sagittal view of the face of the fetus and the limbs. In the axial scan, we start right from the top, from the head. We go down, we look at the heart, then the stomach, then the intestine, and go down to the limbs. Of course, I'm going to show you each of this section individually. So when we look at this mid-set section, what all we see? We see the intact cranium to rule out acrania. We look at the intact anterior abdominal wall, which will rule out your exomphalos and gastroschisis. We can look at the ductus venosus, which is one of the marker in which again we'll see in the sagittal scan. We look at the stomach, the diaphragm, the bladder, everything in this. The one view which we look for is the RL. So whenever there is any abnormality, first I'll show you some normal images and then some abnormal cases. So in this view, when there is acrania, this case, it's obvious that the cranium vault is not formed. There's exencephaly. So acrania with exencephaly, as you can see here in this particular image. I'll have to run quickly because there's so many cases that I have to share. This is a case of acrania with holoprosencephaly. There is no, in the brain, you can see there is a monoventricle with fused thalami, and there is no vault formation. Here, again, acrania with holoprosencephaly. This is the case of a body stalk anomaly in which you can see a grossly abnormal fetus, very short placenta, very short cord, and directly fetus is attached to the placenta. And such gross anomalies cannot be and should not be missed at nuchal scan. This was a case 12 weeks, 5 days pregnancy, non-consanguineous marriage, age 33 years, third gravida with previous one missed abortion, and one female of 8 years. She was Rh positive. Now on nuchal scan, there was a gross subcutaneous fetal edema covering entire fetal body. You can see in the sagittal and axial section. And this patient was counseled for the antenatal testing, chorion villus sampling, but they wanted termination. But remember, even if you terminate, ideally you have to rule out all causes and then counsel the patient. But sometimes you have to respect patient's wishes. But even if you terminate, remember, you always must do the fetal tissue sampling and send it to the genetic lab. In this particular case, we sent it to the for molecular karyotyping or a microarray, which did show a trisomy 21. Okay, so this was the case. Why this testing is important? Because it will not only help us prognostic this pregnancy, but it helps us to prognosticate and counsel for the next pregnancy, whether it's a recurrent cause or not, whether there is any genetic cause which has recurrence, etc., etc. Now, this was a case, you can obviously see this exomphilos, which is senior, in which again you have to do a genetic testing to rule out genetic cause. And if the genetic cause is not there, then you can counsel the patient, monitor based on ultrasound. And this is one of the treatable or operable anomaly. You have to take the opinion of the concerned specialist as well. Now, in the same sagittal view, you will also be able to see bladder in 98% of cases at 12 to 13 weeks. However, to diagnose bladder and kidney anomalies, renal anomalies, we usually wait till 16, 18, 19 weeks because not all of them will be picked up at nuchal scan. However, you can see in this video clip as well, both the kidneys are seen very well in this coronal section by the side of the spine. In the image also you can see, and you can also see both the renal arteries at nuchal scan. And these are two umbilical arteries as you go down, and you can confirm that there is no single umbilical artery. This was a case where there was absence of bladder at its normal position, but there was a mass and which was flanked by umbilical arteries. So we know for sure that this is a bladder exstrophy, which is a very, very rare anomaly, which was picked up again at nuchal scan. Now, we know that when we do a nuchal scan, the maximum longitudinal diameter of the bladder should be more than, it should be less than 7 millimeters. When it is more, between 7 to 15 millimeters, there are almost 20% chance of chromosomal cause. And when it is more than 15, there are higher chance of some structural anomaly and 10% chance of chromosomal anomaly. So this particular case at nuchal scan obviously is having megacystis. And along with that, you know for sure that this cystic structure is bladder because in this color Doppler, you can see it is flanked by two umbilical arteries. So it is nothing but the bladder. And there were also hydronephrotic changes in the kidney, as you can see, both in the image and the video clip. And that is when so early on in the pregnancy, at 3 months, you see such changes, the prognosis is obviously poor because there'll be a lot of dysmorphic changes that you'll be finding in the blood, in the kidneys later on. So prognosis differs versus early development to late development of lower urinary tract obstruction. Now, this was a case of non-consanguineous marriage, but endogamous marriage. History of affected child on maternal side. There was bad obstetric history. There were 2 previous sections and both babies had died 3 to 4 days after delivery, but the details were not available. They were done in somewhere in the periphery, which is again a very sad thing, but a very common thing that we find sometimes when the patient come to us. Now, when I did a nuchal scan, this was a old case. So when I did a nuchal scan, there was again fixed flexion deformities at both upper and lower limbs. And there was, so it was a case of arthrogryposis. And not only that, there was high drops also in this particular fetus. The heart, however, was looking normal. Patient, this was a 3rd baby. Patient wanted termination, but the patient was counseled that even if you terminate, because of recurrence cause of arthrogryposis, there can be a very high chance of genetic cause, and therefore fetal tissues must be tested in a genetic lab, and both parents should also be tested. And they did the same. They went to the government hospital, but they showed the report where they did follow the advice and they did do the trio-exome sequencing after the fetus was terminated. So they did fetal tissue sampling, which did show a homogeneous variant of COSY-related disease, which is an autosomal recessive disease in arthrogryposis. And the parents were also tested for the same genetic defect, and both were heterozygous. That means they were carriers for this condition, and therefore this was the cause for recurrent arthrogryposis. And this was almost 3 years back, and this pregnancy patient was with me. Patient came early on in the pregnancy because they were counseled that in next pregnancy I'll have to do a colon sampling after nuchal scan, which I did in this pregnancy. So the nuchal scan was low risk in this pregnancy. Coronary sampling was then performed by me, and then I sent the tissue for the same mutation. And fortunately, this time, the fetus did not show the same mutation of cozy-related disease. They continued the pregnancy. Patient has now reached, today only I saw that patient has now reached 33 weeks, 4 days. So this is the advantage. It is not just picking up the anomaly, which is important. It is also important to work on those fetuses to either antenatally or after termination and prognosticate and counsel them for the next pregnancy so that they can have a good outcome of the next pregnancy. Now we are going to that was about the sagittal section of the whole fetus. Now we are going to the head. In head, again, we look at the sagittal section, axial section, coronal section. So the section in which we look at the nuchal translucency and nasal bone will give us a lot of information. It will tell us about the thalamus, the intracranial translucency, the cisterna magna, and of course the nuchal translucency. Now this particular section tells us this is the brain stem, and this is the intracranial translucency. So the brain stem diameter, the two brain stem to occipital bone distance, this ratio of BS to BSOB, if it is more than 1, it will, again, it's a surrogate marker of open spina bifida. It tells us go and have a look at the spine closely, because early on at 3 months, the spinal anomalies may not be picked up. But if this ratio is altered, I'm surely going to look very closely to the spine for a small defect also in the spine. So these are the surrogate markers which we can pick up in the sagittal section of the head. Now, this is the axial section in which we can see beautifully this choroid plexus as we go down in the axial section. Again, as I said, we can see the 4-chamber heart. We see that the heart is on the same side. We have confirmed its left side. Situs is confirmed. Then we go down, look at the bladder and the lower limb. And also, we can see both the orbits, the lens, the premaxillary triangle, the primary palate. We can rule out the cleft palate here. Look at the maxillary gap. We can rule out the micrognathia here. So many information you can get from your standard views. So this is how we look at the primary palate. If it is intact, it rules out the hard palate deformities, and the maxillary gap tells us that there are very less chances of micrognathia in this particular fetus. In the axial section, we always look at this beautiful choroid which forms a butterfly, and in the intact calvarium which rules out the acrania and holoprosencephaly. These two anomalies are ruled out based on this. And this particular baby did not show that beautiful choroid plexus, but there was a monoventricle, again a holoprosencephaly, and there was a very rare anomaly. There was arrhynia. The nose was completely absent, and there was this cyclopia. And this patient also offered wanted termination, but we did the fetal tissue genetic testing, and that turned out to be trisomy 13. Now, this was a case. Here you can see the defect in the occiput, and there is herniation of brain tissue. This is a case of occipital encephalocele, again picked up at nuchal scan. Another very interesting case where I suspected something, large rhombencephalon at 7 weeks, 5 days, which I followed up at 9 weeks, again confirmed at 11 weeks. It was again a developing encephalocele. You can see the defect in the bone and the herniation of the brain tissue here. And this was at 12 weeks. It was confirmed that this is an encephalocele. Patient terminated. This looks externally a small defect, but it's a major CNS defect. And of course, we did send this tissue for genetic testing. Again, in the sagittal, the midsection, we can look at the stomach, bowel, bladder, and the diaphragm, and can also look at the any defect in the diaphragm. However, most of the times, even if there is a defect in the diaphragm, it may evolve or may be detectable late, because the herniation occurs late in the second or even the third trimester. Now, this was again a very interesting case where there was on nuchal scan itself. Sorry for that. Okay, on nuchal scan itself, you can see that when you look at the abdominal section, there is absence of stomach here, but this stomach has climbed up. This is a axial section of thorax. The stomach has climbed up in the thorax, and it has pushed the heart completely to the right side. This is right, this is left. And again, in the sagittal section also, you can see that the heart the stomach is in the thorax and it is behind the heart, right? So it tells us that this is a case of diaphragmatic hernia on the left side, and this again earlier the herniation of the stomach and bowel in the chest, poorer is the prognosis. Of course, there are many prognostic factors which are out of the scope of this talk. Cardiac evaluation, again, major structural cardiac defects we can pick up, many of them even at third month. The situs, we can pick up, we confirm the situs, and if the stomach is on left side, the heart is on the left side, we can know that it is a normal situs of the heart. Now, we can very well, with the help of color Doppler, pick up the inflows, as you can see in the clip, as well as images, the inflows, the crossover of major arteries, and the three-vessel trachea view here. So this at least rules out our major cardiac anomalies. Of course, we look at the heart closely at 18 to 20 weeks, because there 90% of major cardiac anomalies we will be able to pick up, but at least 50 to 60% major cardiac anomalies we are able to pick up. So here is a case, again, when we look at the ductus venosus as a marker for trisomy, that will also, this is the triphasic waveform, and out of this the A wave, which is extremely important, and any reversal of this ductus venosus is also a marker for cardiac anomaly. So all these can be picked up right at nuchal scan. Tricuspid flow is also one of the marker for trisomy as well as cardiac anomaly. So any tricuspid regurgitation will tell us, look at the heart closely, because there can be some cardiac anomaly. So this was the case where there was high increased nuchal translucency, tricuspid regurgitation, and reversal of A wave. These are all markers, high NT, tricuspid regurgitation, reversal of A wave. These are all increasing the chance of congenital heart disease by threefold. And in this particular case, the you can see here very well in the even in the video clip that the ductus venosus, instead of inserting in the vestibule and the right atrium, it was directly inserting in the inferior vena cava. I am just freezing this clip here so that you can see that this is inserting in the inferior vena cava. So this is abnormal insertion of ductus venosus. Again, we have to work out, and there was a reversal of the A wave in this abnormally inserted ductus venosus. So all these again, which we can pick up, which are overlapping markers of structural anomalies, as well as the aneuploidy, the high NT, the abnormal, the reversal of A wave in ductus venosus, and abnormal insertion. Now, this was a case, primary gravida, in which there was a cystic hygroma, and the NT was more than 99 centile. You can see very well in this clip, the NT was very, very high. And also there was a cardiac anomaly. There was AVSD here and cystic hygroma and reversal of A wave in ductus venosus. These are the hydrops with cardiac anomaly, and these again are the two markers of cardiac anomalies. And in this particular case, again, we did a genetic test and it turned out to be a Turner syndrome, right? So very, very important to pick them up, counsel the patient, do genetic testing, because it will help us prognosticate the pregnancy now and for future pregnancy. Again, a stomach is almost always seen in all the patients. We can see in this video clip, the baby is gulping the amniotic fluid so well at nuchal scan. So you will be able to see a good AC in the stomach, in the abdominal circumference section. And therefore, it will rule out upper GI anomalies by even in this section. When we look at the axial section of abdomen, you can see the cord insertion in both axial and sagittal section, which will rule out your exomphalos and gastroschisis. So each section that you routinely look at will rule out some of the anomalies step by step. This was a case where there was exomphalos, which was picked up. This you are supposed to look. Now, this is very interesting that upper limbs and lower limbs are much, much better seen at nuchal scan than at anomaly scan. So look at all three segments of the hands, and all three, and also sometimes the open hand you are able to see. And all these segments can also be seen in the sagittal section like this. When you are doing your sagittal sweep of the fetus on either side, you can see the both upper limbs and lower limbs. And again, three segments of the lower limbs. So 3 segments in the upper limb, 3 segments in the lower limbs are mandatory to be documented at nuchal scan, because you can, again, we all know about this case where there was an absent hand which was missed on anomaly scan, and 1 crore fine compensation was to be done by the sonologist. So these are important things to be documented at nuchal scan, and you can avoid such litigations. This is the case where polydactyly was picked up at nuchal scan. However, no major anomaly was seen then, but then I called the patient for early anomaly scan at 16 to 17 weeks, and there were bilateral multicystic dysplastic kidneys, and there was 0 lichar by 17 weeks. So it was a lethal anomaly, and patient wanted termination for that. We sent it for genetic testing, but the patient was not ready for the financially for the testing. So the DNA was stored in the lab. This is another message, that if the patient is financially not ready, always tell your genetic lab to store the DNA of fetus, which costs hardly 2,000. And maybe after 6 months, you can do some genetic testing on this and can find out many anomalies. Please, chairpersons, tell me if I'm exceeding my time limit. I'm about to complete, but just let me know. This is the spine which we can see beautifully. However, always you may not find this sagittal, the supine position of the fetus, in which you'll be able to see the spine and the skin very well. But then we always try to look at, however, spine will be fully seen well by 18 weeks in the second trimester. So major spinal anomalies like this can also be picked up at a nuchal scan. This was a case of sacrococcygeal cystic teratoma with CTEV. So the benefits of early anomaly detection is it allows for earlier and safer termination, even if the anomaly is lethal. There is less risk to mother, favorable cost-benefit ratio, and it can protect the privacy for patients. Not only that, even if the patient decides to continue the pregnancy, suppose there is an exophilus, we have ruled out genetic causes, patient wants to continue the pregnancy, it gives them time to prepare for postnatal treatment, time for them to be prepared mentally and financially, and plan to manage delivery at specialist care. And not only that, we are not here to just pick up anomalies. Those who are at high risk, diabetic patients, or who have had previous anomalies, at nuchal scan, at least 50 to 60% major anomalies can be ruled out, and that will be really a great relief for the patients. In patients with obese women or transabdominal scars, again, the second trimester anomaly scan is also very difficult, where vaginal scan at nuchal scan can pick up many anomalies. But then we must remember there are some anomalies which will never be detectable at nuchal scan: microcephaly, cerebellar anomalies, agenesis of corpus callosum, the skeletal dysplasias, pulmonary anomalies, CCM. So never assure the patient that I've seen everything and everything is normal. There's a legal importance. Always tell the patient 50 to 60% anomalies can be picked up, but it cannot replace your 18 to 22 week scan, and 90% of anomalies can be picked up only at second trimester. So you must offer 18 to 22 weeks scan to these patients. So we must always know about these limitations. And these are just, I have put the various anomalies which should never be missed, at the 9 anomalies which should never be missed at nuchal scan. And therefore, at least we can help all our patients. I think at now, whether it's a rural or urban area in India, we all have a basic ultrasound machine. Most of the patients can you can always offer a nuchal scan with early anomaly scan. At least such gross anomalies are should be picked up at 12 weeks and not at 19 to 20 weeks, because there's lot of benefit for all of our patients. So with this, I would like to conclude my talk. And as a chairperson for the Imaging Science Committee, I always wish, for the same reason, that every obstetrician should be a sono obstetrician or gynecologist. And if I can refine my skills, then I think every obstetrician can. Thank you so much for patient hearing. Thank you.
Excellent, Dr. Bella. That was such a wonderful presentation. And we are indeed obliged to have you here educating us and showing us how much we can do if our eyes are open and our minds are ready to imbibe all the knowledge that you have. Thank you very much. Dr. Sunita?
Yeah, it was indeed a very beautiful presentation. As I'd already told it is always a orchestra of events going on in whatever Bela ma'am tells in her talks. And ma'am, I'll especially recommend you making a copyright of all these videos and sharing it with, in one book form, or because this is beautiful. The pictures you present are always engraved once we see them. So it is beautiful. And I really congratulate you for beautiful pictures, the album of pictures you presented on this.
Point taken well, Dr. Sunita. Thank you for those kind words, and I'll definitely would love to do that. Yeah, thank you so much.
Congratulations.
Thank you.
Thank you, Sunita ma'am, for chairing the session. You were the only batsman for the section. Now we move on to the panel discussion. We have the panel discussion on endometriosis in adolescent girls, which will be moderated by Dr. Bharti ma'am. So the chairpersons for this session are Dr. Parag Beniwale sir and Dr. Rosa Olai ma'am. I welcome you both, ma'am. I request Dr. Shanta Shekhar, she is our EC member KSOGA, to introduce the chairpersons.
Good evening, all. Thank you for the KSOGA for giving me an opportunity. Let me have our chairperson's CV, please. Okay, the first chairperson for this session is Dr. Parag Beniwala. Dr. Parag Beniwala is the chairman-elect for our ICOG for this year. He's a senior consultant OBGYN from Pune. Dr. Parag is PG teacher and unit head at Kamla Nehru Hospital. He was the president of Pune OBGYN Society from 22 to 23, national website editor for Foxy from 2011 to 2017. He was a peer reviewer for the Journal of OBGYN of our Jogi from 2011 to 2017. Chairman, Young Talent Promotion Committee, 2008 to 2010. Doctor is co-editor of the book Gynecological Manual on Adolescent Girl and Young Women, Yearbook of OBGYN 2019, Exploring New Horizons of OBGYN. Delivered orations, guest lectures in over 160 Foxy Society, recipient of Dr. C.S. Don Prize, 51st AICOG in New Delhi, 2008. May I have the next chairperson's CV, please? Another chairperson is Dr. Rosa Olaya. She is the director of Olaya Hospital and Research Center at Gwalior. Doctor is president at Gwalior. Doctor is the president-elect Gwalior Obstetric and Gynec Society 2024 to 25. She is chairperson for SBC Madhya Pradesh 2020. Of FPI from 23 to 26. Madam is the Vice President Foxy in 2014. She is fellow and member board of Governing Council of ICOG 2018 to 21. Chairperson Adolescent Health Committee in 2012. Madam is FIGO representative for WHO in the FIGO World Congress at Rome in 2012. She is WHO consultant expert panel meet for making global guidelines on adolescent sexual health in Geneva 2010 to 2011. Many national awards and publications to her credit. She is awarded the prestigious Dr. D.C. Datta Prize Award for the Foxy Best Publication in 2011. Awarded the prestigious Mehro Dara Ansotia Award in 2010 to 2011. She has over 100 peer-reviewed publications in index journals, CMEs, in textbooks. She has authored 4 textbooks and co-authored 8 books in OBGYN. Here I present to you the chairpersons, Dr. Parag Biniwala and Dr. Rosa. Thank you.
Thank you, Shantama.
Yeah, thank you and good evening. I bring greetings from ICOG. It's indeed a pleasure to be sitting next to a very dear friend, Dr. Rosa Olai, who's my co-chairperson today. At the outset, let me thank Team KSOGA, especially President-elect Dr. Bharati Rajsekhar, for asking me and Rosa to be sitting as the chairpersons for this, which I believe is going to be very, very interesting panel discussion. Adolescence is something which is a fascinating area, and Rosa and I share the same passion for the adolescent health. Bella, your talk was wonderful. I was listening to it while I was traveling, but then the pictures were amazing, and you're doing excellent work. Please continue doing so and educating all of us here. So, Rosa, may I request you to give your comments, and then we hand over to the to the moderator, Dr. Bharati Rajsekhar.
Thank you, Parag. It's indeed a pleasure, first of all, to meet you and to be at the same stage with you. Brings back all the good memories we had together and such wonderful work you had done when you were the chairperson of Foxy. And we want to look you forward to come, and climb the hierarchy soon. Well, at the outset, again, I would like to congratulate Dr. Bharati Rajsekhar for organizing this and inviting me and Parag together. And thank you so much for the privilege that, to see all of you dear friends in Karnataka. It's a pleasure to see young coordinators, Rachna and Shobha, doing the work. And I'm so happy, Bharati, that you pick up the young talents. That is what Parag's committee was, And I'm sure he agrees with me. And Bella, you spoke excellently well. I've messaged you also, and it's so good to see you here amongst the friends that we have. So I think we don't want to waste more time, and Parag has already spoken well about the session. I would like dear Bharati to start the session. It's a very, very interesting session on adolescents. And yes, endometriosis gets a little missed out in adolescents, thinking it's a dysmenorrhea. So I'm so happy you brought up this. I'm being the endometriosis, I think month. I don't know whether the chairperson is here with us, Anu, but I think we can go ahead.
She's there. Dr. Anu is there.
Anu is there? Okay, couldn't see her. Right. Okay, so please go ahead.
Yeah.
Do we need to introduce you, Bharati?
Yes, ma'am. Kindly
okay, Dr. Rosa, no, it's my own society. So at the outset, I would like to thank, of course, Dr. Rishikesh Pai for having been our chief guest, and Dr. Sunita and Dr. Shaijas, Dr. Madhuri and Dr. Nagaraj for having blessed us. And of course, I have no words to express my thanks to Dr. Rosa and to Dr. Parag, because as you said, as you both believe that adolescent health is the future, we need to build upon the generation next. I have also continued to follow this policy for the past 30 years, educating and creating a lot of awareness and empowering these young girls. I believe that that is where we can make the change in our society for the betterment of women's health. And I thank the KSOGA President, Dr. Vidya Thobi, and Patron, Dr. M.G. Hiremat and Dr. Nagaraj, for bestowing the responsibility of conducting this Gyaan Sangam program, which is the 6th episode. And of course, I have my two right hands and left hands, I would say Rachna and Shobha along with me. So let us just have the CVs of the expert as well as the panelist, Dr. Rachna. Have a short introduction.
Yes. I don't kindly share Anu Chawla,
Dr. Anu Chawla and the other panelists. So, well, March, as you all know, is the month of Dr. Anu Chawla. First, March is the month of the endometriosis, and we taking up this theme of Gyaan Sangam, where we are connecting the north, south, east, and west of India. We also have our own Dr. Anu Chawla, who's been the chairperson of Endometriosis Committee, FOXY, who took up charge in 2024 all the way from the United Kingdom, who will be joining us as an expert, and what more could we ask for? So we welcome you, Dr. Anu, to this panel on adolescent endometriosis. Then we have a very eminent team of panelists with us here. Could I have the panelists CVs, Arun? Yes. So we have Dr. Seha Buyar, who is very familiar to all of you. She has been the breast committee chairperson, and she is now going for the West Zone Vice President, and she is our academician par excellence with numerous awards to her credit. She comes from a very small society, but she has headed a lot of programs like the Foxy Breast Committee, 2019 to 21, GCM of the ICOG. She's been the National Adolescent Trainer of WHO FPI certified, a national expert for UNICEF, the peer reviewer of Jogi, and AMOG's chairperson medical disorders for 22-24. And she's also in the AMOG's chairperson emergency obstetrics 24 to 26. She's the Mission Health, Pink Health Committee and convener of PCPNDT. She's been in the Suffolk Working Group member on breastfeeding. She's been the former founder president of ISOPARB of Vidarbha, the president of BioGS, and that is the Yavatmal Society, and she's the founder of the clinical secretary of the Yavatmal OBGYN Society. So we welcome you, Dr. Sneha. The next CV, please. Yes, we have Dr. Udayan Sarkar, who is from Siliguri. So you see what Gyaan Sangam can do, connecting people from all over the country. It makes us feel so good. We are all one here. Sir is a professor at the Department of OBGYN of the MGM Medical College, Kishanganj, and a senior consultant at Siliguri. He is an undergraduate and postgraduate examiner, the honorary secretary of Siliguri OBGYN Society, and he has organized the East Zone Yuva Foxy in 2020. We welcome you, Dr. Udayan, to this panel of ours. Yes, and then we have Dr. Geetanjali Kaur, who is also a very eminent academician with her gold medalist from PGI JIPMER, which means a lot. She's the director and senior consultant of Pal Hospital from Ludhiana. She has 26 years of clinical experience. She has organized the North Zone Yuva Foxy in 2022. She is the president of the Ludhiana Obstetrics and Gynec Society. She's been the secretary of SFM Ludhiana, a speaker at various national and state level conferences. She has a special interest in high-risk obstetrics, ultrasound, laparoscopy, surgery, and infertility, and she is a recipient of Icons of Punjab Award in the year 2022. We welcome you, Dr. Geetanjali. And we have Dr. Banu Sri Lakshmi, who comes from Bodhan in Telangana. She's a senior practitioner at Maruti Prasanna Matru Shishu Nursing Home. She has interest in high-risk pregnancy and conducting various programs on adolescent problems, anemia, girls' child rights, women rights. She works as Nizamabad Foxy president from 2022 to 23. And I think Dr. Banu is right now out in an adolescent health education program, but will be joining us shortly. Next. Do we have the next panelist? Well, we have Dr. Indira, who is from Karnataka, Tumkur, where Dr. Rachna comes from. She is professor and HOD of the Department of OBG of Siddhartha Medical College. She has various publications to her credit. She is interested in infertility, endoscopy, and high-risk pregnancies, organized various CMEs and workshops in the state level, and she's been the vice president of the Tumkur Society in 2015, and right now she is the secretary of the Medical Disorder Committee of KSOGA. Next slide. Yes. And then we have Dr. Bimba, who is from my own town, Hassan, a very young obstetrician and gynecologist coming up in a good way. She works at the fertility consultant at Mani IVF Hospital, and she has a fellowship in reproductive medicine. She has a diploma in reproductive medicine from Kiel University, Germany, and a fellowship in gynec endoscopy from Maharashtra. So, are we done? I think we have one. Yeah, I think we are done with our panelists. So, without wasting much time, I think we will take up I will share my screen and we will go on to the discussions. Yes, ma'am. Hoping to have a very fruitful discussion with all the doyens of adolescent health as well as endometriosis right over here. So we welcome you once again to this adolescent endometriosis panel discussion. Yeah, and of course, all of you know, and just to set the ball rolling, endometriosis is a condition in which cells similar to those in the endometrium, the layer of the tissue that normally covers the inside of the uterus, grows out of it. And we all know how big a problem it is and how many women are suffering because of endometriosis. The quality of life has been hampered, and as well as that, they have got a lot of social, mental, as well as economic issues when they suffer from endometriosis. So I would like to put this question across to all our panelists. How often do you see early onset endometriosis in your clinical practice? I would like all the panelists as well as the experts and chairpersons to opine on this. Dr. Udayan? Dr. Bimba?
Very good
Yes.
Good
Yes,
evening,
sir.
madam. Thanks
Good evening.
for inviting me in the panel discussion. Now, this is such a problem, early onset endometriosis. The diagnosis is difficult. We do get a lot of patients presenting with dysmenorrhea, and we are often confused whether it's primary dysmenorrhea or it's endometriosis. So the diagnosis is difficult, and it's very difficult to say when a patient comes in adolescence whether it's endometriosis or not. That is the difficult part, and we do understand after treating them with, say, COCs or a certain length of time, maybe we are looking into endometriosis.
Any other opinion from the panelists?
And the exact incidence of or prevalence of endometriosis is not that known in adolescents. However, those adolescents who come with chronic pelvic pain, it has been found that around 25 to 38% of them do suffer from endometriosis. Still, larger studies are required to know the exact prevalence of endometriosis in the adolescent age group.
Thank you, Dr. Udayan and Dr. Bimba.
Yeah, Bharti, can I just
Yes, sir.
add
Yes,
something?
Dr. Parag, please.
Yeah, I totally agree with Udayan and Bimba. Diagnosis is difficult, but then whenever any girl comes to us with progressive dysmenorrhea, we have to be very, very alert, and then we have to start thinking in terms of endometriosis. Of course, ultrasound will give us a good clue, but typical history is progressive dysmenorrhea. It is not relieved by any painkillers, and she continues to be more and more miserable as the cycles keep on coming.
Thank you, Dr. Parag. So as you all said, rightly said, when we look into those girls who have taken treatment for progressive dysmenorrhea and later on we do a laparoscopy, we are seeing almost 50 to 70% incidence of endometriosis in them in different grades. So we need to keep our eyes open for them. So what are the factors which point towards early onset endometriosis, Dr. Bimba, or any of the other panelists?
Early onset endometriosis is mostly suspected when an adolescent who comes with, as Sir said, severe dysmenorrhea, which would not be relieved with NSAIDs. So before telling about this, dysmenorrhea is of two types, primary and secondary. Primary dysmenorrhea is when, with the onset of puberty or menarche, around 6 to 8 months later, when the ovulatory cycle starts, because of secretion of prostaglandins and leukotrienes, there will be dysmenorrhea. Usually, it is relieved by NSAIDs. However, secondary dysmenorrhea, when it is associated with some pathology, may not be relieved with NSAIDs. In that case, we have to suspect endometriosis, especially in a young adolescent. Along with that, they'll have some systemic symptoms. They may have gastrointestinal symptoms. They may have dysphagia. They may have dysuria. And also most important according to ISHRE is school absenteeism because of dysmenorrhea. Also in such adolescent individuals, we have to suspect endometriosis.
Yeah, I think rightly said by our previous Dr. Parag, our chairperson, and Dr. Bimba, that we have to suspect first, especially when it is persistent, clinically significant dysmenorrhea, which is not responding to the regular anti-inflammatory drugs, and it is affecting her quality of life. So what are the peculiarities? What is the difference between adult onset endometriosis and early onset endometriosis? As Dr. Banu back there, Dr. Rachna, or Dr. Indira, Dr. Geetanjali can take the question.
Ma'am, Dr. Geetanjali had an emergency. She too had to leave, ma'am.
So is Dr. Banu there?
Banu ma'am is also not here, ma'am. I think she's held up in a talk, ma'am.
Then we have Dr. Indira, right? Dr. Indira is there.
Yes, ma'am. Indira is
Dr. Indira.
Peculiarities of early onset endometriosis is patient presents with primary dysmenorrhea. I think we should change the way we are evaluating primary dysmenorrhea. As the origin of the disease also is different when compared to adult variant. Early onset endometriosis patients, they will have more of superficial peritoneal disease, which is very difficult to diagnose by ultrasound.
Yeah, so we have to always think of this because the etiology is going to be a little, the appearance of the other endometriotic nodules are not like the powder burn spots or the chocolate cysts that we generally see. They will generally be clear or red and can be very difficult to identify if we are not familiar, and hence we have to keep our eyes open for this. Would the expert, Dr. Anu, like to opine on this? Dr. Anu, are you there?
Yes, Dr. Bharti, I'm here. I
Thank
would
you, Dr.
request you
Anu.
to please repeat it because I've
Yeah, we would
just
like you to
missed
opine
the.
as to what is the difference. I mean, what significant features would you enumerate about early onset endometriosis?
Sorry, sorry. Once again, can you repeat? Sorry for that. Sorry.
Please
I'm
take
in
the
a
others.
little noisy background. Sorry for that. Can you repeat the question?
Yeah, so we would like to ask you that one, in your practice, how often do you see early onset endometriosis? And what are the significant pointers towards early onset of endometriosis in your setup?
In my setup, I see IVF patients only, Dr. Bharti. I'm not
Okay,
the
right.
right person. So I'm having the London Fertility Clinic, as you saw in my CV.
Yeah,
So my
yeah.
patients come to do IVF. So I don't see the early onset for since 2012. So not the right person for the question. Sorry.
Okay, okay. Thank you, thank you.
Hello,
So
ma'am.
now, what I would like to
Yes.
ask Dr. Udayan, sir, what would be the etiology of this early onset of endometriosis? Because as postgraduates way back, we were always told that endometriosis and adenomyosis were diseases of midlife, were diseases of the higher income group. But now we see that there is a paradigm shift towards early onset endometriosis. So, what could be the etiology of this?
Yes,
Since
ma'am.
Dr.
There has
Gitanjali is not there, Dr. Udayan can take the
Yes,
question.
there has been a lot of theories regarding early onset endometriosis. The cases that I have seen is, obstruction in cases of cryptomenorrhea. They do develop endometriosis. Yes, you have a lot of theories. So the exact cause you can never pinpoint. But as you see, there is, Samson's theory says that there is retrograde flow of menstrual blood, and that results in the onset of endometriosis. So, madam, it's very difficult to say the exact cause, what causes endometriosis as such.
Would any of the other panelists like to give their opinion, or our expert,
Ma'am,
or even our chairpersons?
ma'am,
So,
now
Dr. Bharti,
Yes, Dr.
can I
Rosa. Yes,
suggest?
Dr.
Yeah.
Rosa, please.
So in the ISHRE, the latest endometriosis guidelines in 2022, it was also mentioned that you have to take a history of the girls with a family history of endometriosis. And of course, where Dr. Udayan very well mentioned that there could be some anomalies, some obstructive anomalies. So maybe an ultrasound could also help us, with our tools to diagnose.
Sure.
So we have to have a history of obstructive, early menarche,
Yeah.
this history also comes in the history.
Early menarche and scanty flow is also something that we need to look
Yes,
into.
that's right.
But the origin of early onset endometriosis, there are very interesting literature on this, which says that there is a newborn uterine bleeding. So this newborn uterine bleeding causes a reflux of the naive endometrial progenitor cells into the peritoneal cavity, which remain dormant till menarche or thelarche. They get activated at thelarche under the influence of estrogen, and later on they develop a florid early onset endometriosis as early as even 15, 16, or 17 years. So this is one of the reasons for early onset endometriosis, and they say that there are some conditions which have an increased risk of neonatal uterine bleeding, which could be low birth weight, preeclampsia, post-maturity, and a fetal-maternal incompatibility could lead to early onset endometriosis.
ma'am,
So
one
that
more
is
thing I
something which
want
is
to
very
add.
interesting.
One more thing I want to add, ma'am. Now the menarchal age is sinking, and girls are exposed to phytoestrogens nowadays. So the incidence is also very increasing.
Coming up earlier. We are picking it up quite earlier. Thank you, Dr. Indra, for that input. So now let's come to case one. There's a 15-year-old girl brought by her school teacher saying that this girl had severe abdominal pain and vomited once while she was in class. And the girl on taking history had said that she had the pain since 5 days. So she was immediately brought to the emergency room, and then her parents were sent for. And on taking the history, she said that she has a normal menstrual bleeding usually, and her LMP was just 1 day ago. And she reports that she does have associated constipation and diarrhea when she has her periods. And on clinical evaluation, it revealed there was no systemic diseases, no previous surgery. Her body mass index was well within normal, 24.9. And she had, on a clinical examination, she had just a few spots of acne on her back, which is common in this age group. And she had localized a deep abdominal tenderness. And abdominal examination, there was little tenderness in the low pelvic area. So, Dr. Indra, how would you assess pain in this particular girl? Because
Yes,
that is
ma'am.
the main component of endometriosis.
Yes, ma'am. Just by the fact that teacher has got the student, I think the pain is severe. And if I have to assess on a visual analog score, I can ask her to score anything more than 8 on 10 is significant. And I can ask her to, I want to ask her whether this is the first episode or recurrent she is having, so that I can ask her to tell the difference between the usual pain. I can ask her to rate the usual pain and the new onset or progressive dysmenorrhea.
Yeah, thank you, Dr. Indra. Exactly. I think we need to take a detailed history of the pain because sometimes we think that she is malingering. Most often, when they come, young girls come at that age, we clinicians tend to overlook these symptoms and tell them it could be just a stomach upset. So we need to score it and find out whether it prevents her from doing her homework or going for sports or even attending class. So when we analyze the score, we said that this girl had a score of about 8 on 10. So when she had a score on 8 or 10, how would you next proceed? Dr. Sneha? I think Sneha was in another meeting. If she's there, Dr. Sneha, are you there? Rachna, do you see Dr. Sneha ma'am there?
Ma'am, I don't see her.
And I think Dr. Bimba or you can take the question. So she has come with pain. She's in your hospital. What are you going to do? And she says it is repeated.
First of all, I would like to do a full bladder ultrasonography. First, I will analyze her history. History is extremely important, and also sometimes there may be family history of endometriosis in the siblings, mother, or the sisters. And full bladder ultrasonography is extremely important. Sometimes we may pick up, but most of the time, especially in early minimal or mild endometriosis, which the adolescents suffer, we may not find any findings. That's I would like to do some.
Yeah, what I would like to say, any other opinion from the experts or the other panelists?
Ma'am, history is very important. We have to take whether it is cyclical, acyclic, and associated atypical symptoms like does she have any 5Ds like dysmenorrhea, dysphagia, deep dysmenorrhea, and then secondary dysmenorrhea. Whether what is the pattern of her cycles? Like is she having short cycles? And we have to look at her profile also whether she is obese or lean. It is more common in lean, and we have to look into other symptoms before considering endometriosis.
Yeah. I think this detailed history of her menstruation, when she attained menarche, family history, the amount of bleeding, and the associated bowel and bladder symptoms need to be elicited. And also her past medical history, whether she has just taken over the counter painkillers and now she comes to us because she has no response. And thirdly, family history is also important. And along with that, how is it affecting her quality of life or her studies? And does she have any other issues related to this other than her pain component? So we have to take. So on taking the history, we know that her mother is taking progesterone therapy for a referred endometrioma and deeply infiltrated endometriosis in the rectovaginal space, which she was evaluated. And this young girl also has taken NSAIDs whenever, and she had often missed schools because of her dysmenorrhea. So that's what happens. See, this endometriosis leads to a very psychosocial impact on this young girl. And if we delay this, we know that because actually there is always a delay of about 6 to 7 years before we actually start treating them for endometriosis. So it's very important that we need to catch these young girls as early as possible. Because if you see this study, women with pelvic pain and endometriosis reported lengthy delays between the onset of symptoms of pelvic pain and the diagnosis of endometriosis. If you see in most of the Western countries, the onset of pain was as early as 18 to 20, 21 years. But however, the diagnosis of endometriosis was only made in the early and the late 30s. There was a delay in therapy for almost 7 to 10 years. So this diagnostic delay of endometriosis has to be addressed, and we need to see that we open our eyes and try to catch them as early as possible. So how could we avoid this delay? Dr. Sneha or Dr. Udayan? Dr. Bimba is there. Could any of you take this question? What can we do for
Now that
keeping
we are,
this?
yes, ma'am. Now
Madam,
that
we
we
need
are
to be
already allowed.
endometriosis minded actually. Like, something like ectopic pregnancy, we need to be ectopic minded, because whenever a girl comes with severe pain, which is progressive with early menarche and all related family history, we always need to have in the back of our mind that it may be endometriosis, and the relevant investigations we should start doing, especially if she also has a history of dysphagia, dysphagia, and hematuria.
Thank you, sir. As you rightly said, we have to keep our eyes open and suspect endometriosis rather than just saying it is dysmenorrhea, you will be okay. So these are some of the factors which will point towards endometriosis. The family history. Please mute the non-speakers, Arun. And early menarche and shorter length of menstrual cycles do point towards a diagnosis. And how are we to avoid this delay? We need action to improve diagnosis of care for people with endometriosis. So we have to have resources to support fundamental research. We have to improve medical education regarding menstrual health and signs and symptoms of endometriosis, even in the adolescent age group, because most parents would just tell them that it is regular. All of you will have pain during your periods. It will be over once you get married. It will be over once you get have a baby. So these are the myths that we generally come across. So there needs to be a lot of education for our younger children, for the adolescents, and we also have to have a standardized delivery of multidisciplinary care when it comes to management of dysmenorrhea, which is progressive in this adolescent age group. So we have to differentiate between primary dysmenorrhea or secondary dysmenorrhea. So Bimba, could you elaborate the other causes? Because just because it's secondary dysmenorrhea, we cannot label her as endometriosis. So what would be the differential diagnosis in this girl?
Yes, ma'am. Most of the causes of secondary dysmenorrhea in adolescent is endometriosis. And apart from that, important cause is congenital malformations. There might be cervical stenosis, there may be imperforate hymen, there might be a vaginal septum, ovarian cysts, there might be fibroids or adenomyosis, though they are less common. Congenital uterine anomalies, if there is an accessory rudimentary horn which is functioning, and if it is removed, most of the symptoms would be relieved. Most of the obstructive congenital anomalies, if they are treated properly, the patient may become symptom free. The adolescent, if she is continuing with this Mullerian obstructive anomalies, they themselves are at more risk of endometriosis. Apart from this gynecological causes, other non-gynecological causes, surgical causes, like there might be appendicitis, there may be a urological causes like a obstructive ureter or a stone, congenital obstructions in the urinary tract, or there may be gastrointestinal disorders which we have to rule out. Suppose the adolescent is sexually active, whose surgery is extremely important, we may have to suspect pelvic inflammatory disease and also sometimes adhesions.
Yeah, sorry. I'm sorry. Just give me a minute. I'm going back. I have just touched something. I'm so sorry. So thank you, Dr. Bimba. As you said, that it is not, so once somebody comes with progressive abdominal pain, or she's absent from school, it will not point just to endometriosis, though that would be the commonest and the first diagnosis that we would make in young female children. But we would also have to think of the non-gynecological and other causes of pain due to which could cause this problem for her. So as you said, you have already elaborated. Dr. Banushi, has she joined? No. So what are the common complaints of endometriosis? I think we've already touched on this. It's usually pain, abnormal uterine bleeding. Of course, in little elderly girls, maybe in the 20s, they would have.
Madam, Dr. Geetanjali Kaur was there.
Okay, Dr. Geetanjali, we welcome you. So let us move to the next questions here, because we know that these are the common issues. So this is what, along with these pain and irregular bleeding and fertility issues, we have to be very careful when we talk to these girls, because they have a lot of psychological disorders. They may have somatic symptoms, and it affects their human relationship and their sexual relationships also. So, Dr. Udayan, does a early onset endometriosis just affect her only physically, or does it also affect this girl's mental health?
It definitely affects her mental health also, because from a school going girl, if you see, frequently they'll come with history of absence from school, or ultimately they try to avoid going to school. The parents may feel that she's maybe her problem, she's not true to herself, but she in severe pain, and then she becomes anxious. She maybe she does not perform well in school, and ultimately when she grows up, she may have fear of adjusting to her career. If she is married, she may have dyspareunia, sexual dysfunction, and all marital issues, and ultimately depression, infertility, anxiety. All these are problems that may crop up, which leads to deterioration of mental health.
Yeah. Thank you, Dr. Udayan, on that. As you rightly said, this early onset endometriosis is going to be a very distressing problem, which is going to make her whole life a roller coaster ride. Like, every moment she is being put off by this pain. So there are social issues and definitely mental issues, as you very well elaborated. I would like Dr. Rosa or our expert, Dr. Anu, to also give their inputs on this. Dr. Rosa, you've been into
Yes,
adolescent health.
Definitely.
yeah. Anu, go ahead.
Thank you, Dr. Rosa, and my regards to all of you present there. Dr. Bharti, thank you for having me, Dr. Parag. So basically, of course, this is one thing. If I say only one point in the webinar, that would be the delay has to be avoided. It's for too long that we leave women alone. It actually can affect them thinking that they're not being women enough, and probably all women, other women, are probably being strong enough to face this, which is such a mentally devastating thing to live with over the years. The whole lifestyle, the ability of the person can be devastatingly affected very badly. So this is very important. Now, we often say it's in your mind, but when it is in your pelvis, actually. So first you rule out that, and that brings us to technology. We need to understand a nice ultrasound training has to be there. We need to do a nice use of imaging to diagnose, because another thing is, now in the name of diagnosis, the number of surgeries should not go high. So just because we are campaigning so much through our endometriosis committee of Foxy that you please do everything possible to diagnose early, that does not mean at all that we are promoting the increase of number of surgeries given to the patient, and also the number two, then the number of times the patient is being told in the clinic that go get pregnant. These two things have to be avoided. We need to be ourselves so fully equipped and trained that we can do a nice use of imaging to see if there is endometriosis. Of course, subclinical might need a laparoscopy. Repeated medical use of OC pills or Dynogest is not being, relieving the symptoms of the patient. So very carefully, we have to avoid surgery. Every surgery is a possible risk of surgery and anesthesia, and also the use of other conservative modalities. Keep the patient coming back to you at least a frequency of once in 6 months. That is also a good way to make sure that she's having a good quality of life. Thank you very much.
I think that was an excellent message by you, Dr. Anu. Do not delay, do not rush into surgery, because there are wonderful medical management for endometriosis. But of course, just don't tell her go and become pregnant, because that is her own personal issue. So we need to address her problem for what she comes to us, because obviously she comes for pain and not for a pregnancy. Over to you, Dr. Rosa.
Yeah, so when we talk about the psychosocial aspect, it is a very, very important aspect, because I have come across my patients who literally have lost their jobs because how often they can leave, they go on leave. And even students, they come into with depression and even, difficulty in getting pregnant. There are a lot of things associated with endometriosis, and we have to, give importance to this aspect. And I'm, Bharti, so happy that you've highlighted this aspect, because it really affects, she cannot sleep at night, she's irritable, and, the partner or the family members cannot understand her. So this is so very important, and the early diagnosis with proper treatment will give her a long way to live a good life. It's really one of those most painful experience a young girl can have. And we deal, of course, with adolescent right now. Leave aside the infertility and other factors which are going to be there with her.
Yeah, so thank you, Dr. Rosa. And as you rightly said, we need to spend time with these children as well as with their family members and make them understand what is the disease process. Because otherwise, they would say, come to you every time, doctor, you just give us some pills. But still, she's depressed because we may give her the pain concept, pain aspect may reduce, but still her mental stress will still continue. So we have to address that, which is very, very important. So we have to take care of not only physical problems, but as well as her psych problems. We have to take care and talk about it. So now, Dr. Geetanjali, we would like to say this girl has come. We have a family history, and we suspect maybe she has endometriosis. We don't know. So how are we going to manage this young girl? Rachna, Dr. Geetanjali, you said has joined? No.
Yes, ma'am, she was there.
Okay, Dr. Bimba, you can take it. Any of the panelists. So how to go about this young girl? What are you going to do for her?
So, as we all know, we are going to, first of all, we have to elicit the history, or careful history taking is the one which is extremely important. Secondly, we have to examine the patient. That is, sometimes if they are cooperative, we can do a PV examination or a rectal examination. We have to assess her symptoms like bowel symptoms and her quality of life which has been affected, whether there is school absenteeism. History and clinical examination has to be done, followed up by ultrasound, bladder full ultrasound, or the role of MRI in adolescent is still not
We'll come to that. We'll come to that.
It's
I
still
just want,
controversial.
yeah, Dr. Bimba, I just want to put this message to all the panelists. Well, there are reports of saying that you could do a PV or a PR for diagnosis. So, what is the opinion of the panelists? And then we come to the guidelines. What do we do in clinical practice?
Now that we are considering endometriosis, early onset endometriosis as the diagnosis, the biggest challenge for us is to establish the diagnosis. So, how to establish diagnosis? So, while considering per vaginal or per vaginal, if she is sexually active, we can do. Per rectal examination, we have to consider her age and the cultural background before doing per PV or PR for diagnosis.
Yeah. Anybody else? Dr. Udayan? Dr. Rosa? Yes, sir.
Basically, it depends whether, first of all, the adolescents, young adolescents may be unmarried, and PV would not be a proper examination for them. So with consent, we might do a PR, and PR will also give at least enough information if she has an endometrioma or something of that sort.
True, sir. So, though the recommendations say that you could perform a vaginal or a rectal examination, we have to take the cultural background, and it has to be discussed with the adolescent and her caregiver, and only then taking into consideration, because if she's just 14 or 15 years, definitely I would not like to do a per vaginal examination, but maybe with some explanation and cajoling, we could always do a per rectal examination. But as Dr. Anu said, we have got wonderful imaging techniques today, which could overcome these cultural problems we face in our practice. So, which diagnostic procedure should be applied in adolescents, Dr. Udayan?
Ultrasound. Ultrasound should be the first modality for diagnosing endometriosis, and it's very useful in diagnosing chocolate cysts or ovarian endometriomas. Ultrasound may not pick up all types of endometriosis like peritoneal, superficial peritoneal endometriosis. And ultrasound, I should say, is the ideal. If possible, we can do a TVS if she is married, or else we can do a transrectal ultrasound also.
Yeah. If she is appropriate and she's been sexually active and she's 19 or 20, we could always do a transvaginal. Otherwise, a good transabdominal scan or even a transperineal or a transrectal scan can also be considered. So, what is the place of MRI now? Dr. Indira, could you say what is the role of MRI in adolescents?
MRI is expensive and it has got a poor sensitivity in detecting the deep infiltrating endometriosis. It is suitable for posterior compartment lesions.
It's a second level examination and not to be routinely indicated for just the diagnosis of an endometriosis. So there is no correct consensus, but generally we do not perform. So Dr. Sneha is not there. So any of you can take. What is the place of sero biomarkers in diagnosis?
I think
Not
poor.
indicated.
Yeah.
Not indicated.
All the panelists, the experts opine that there is no role for CA125 or any other markers in ruling out endometriosis. So what is the best treatment you would like to do for these children with suspected endometriosis? We've done a scan, there may be some probe tenderness, or we've done a PR, there's some tenderness and she has progressive dysmenorrhea. So what are we going to do for her? Are we going to rush in and do a laparoscopy or what are we?
No. Medical. We should start with medical treatment first.
Yes.
We should start with medical treatment. Whatever treatment we decide upon, maybe cyclical COCs or progestins.
Yeah, and Dr. Indra, what are the goals of medical management?
Yeah, main goals of the medical management are to symptomatic relief, and if endometriosis is left untreated, it may jeopardize her future fertility. So protection of future fertility is important, and suppression of disease progression without avoiding delay.
And we also need to protect her future fertility. It is very, very important. That is why we put her on medical therapy, because definitely medical therapy will not compromise her future fertility like a laparoscopy may sometimes do. So we have to relieve her symptoms because we have to improve her mental health and physical health. And of course, suppression of disease progression is very, very important. We have to suppress as far as she wants it to, because earlier when we were postgraduates, we were told two things. For endometriosis, if the girl is married, tell her to become pregnant, or you give her a pseudo pregnancy state. So nowadays we can't say that to any of our patients and tell them. So we have to individualize the treatment depending on for what she has come to us. So it has to be counseled along with the patient's choice as well as the caregiver's choice, the need for contraception if she is sexually active, and if are there any contraindications or any adverse effects. We need to counsel the adolescent and her family about all the other treatment options available. Dr. Udayan, how would you manage her pain concept? You said medical management, so how do we manage the pain?
Immediate pain should be managed by NSAIDs, but we should always start with COCs or progestins cyclically. And if she responds, we can put her on long-term COCs. But if she does not respond, we should always have, suppose we do not get anything on imaging and she is not responding to COCs, we should always have endometriosis in mind and proceed accordingly. And the treatment, medical part, either COCs, progestins will include Dianogest and say norethistone acetate. And for pain, we can always give NSAIDs.
Yeah. So we have to give her supportive therapy of pain analgesics like NSAIDs, and if she has nausea, vomiting, we have to give her supportive therapy. We have to give her progestin or OC pills medical therapy, as well as we need to give her psychosocial counseling that also goes along with the therapy. So Dr. Indra, what is the mechanism of action of progestins which we advise?
Yes, ma'am. So none of the progestins are superior over other, but with the available progestin preparations, the results are promising. And mechanism of action is it is anti-angiogenic and anti-proliferative. So it suppresses the pituitary ovarian axis and it reduces the size of the endometriotic implants.
So it acts anti-estrogenic and also anti-inflammatory and anti-angiogenic, and that's how the progestins act. And as you already elaborated, the preparations you could use are what we use. I would like the panelists to say what you generally use in your practice.
Dynogest.
Yes, Dynogest we do use. Of course, even OC pills and just plain medroxyprogesterone acetate also helps, because Dynogest is quite expensive. We may not be able to give it to all our women. They may not be compliant. So even medroxyprogesterone acetate is also, any norethindrone acetate is also good enough. Dr. Rosa, would you like to opine?
Absolutely beautifully said by the panelists. Yes, the first choice would be OC, progesterones. If by chance this doesn't work, then we can think about giving her amenorrhea by GnRH analogs with an add-back therapy, which is for a long term. So that comes later on. But in my experience, I've seen that OC, especially nowadays, we have a combination of Dynogest and etanyl estradiol. So that really works well. The pain factor and the heavy bleeding also is taken care of. Basically, the nutrition part also we have to think about with these girls. Basically, they are lean, very thin patients. So we have to think about that factor as well.
Thank you. Thank you, Dr. Rosa. So we know the anti-inflammatories. So what does the GDG recommendations of ESHRE tell us is, for severe dysmenorrhea and associated pain, you can give hormonal contraceptives or progestins, and of course, LNG-IUS if the setting and the cultural background is okay. Or if you're doing a laparoscopy, you could always counsel them and insert the LNG-IUS after a laparoscopy. Pain management, NSAIDs, along with progestins, especially first-line hormonal therapy, is not an option. We would have to give them NSAIDs. And of course, this laparoscopic confirmed endometriosis should not be the first line of management. And as Dr. Rosa, you told that GnRH agonists can be considered when they are not responding to the medical management of combined OC pills or progestins. Of course, always with a note that you have to have the add-back therapy, which will be covered. So is hormonal therapy enough, Dr. Geetanjali? You've done medical management. Is that all that is needed for this young girl? Anybody? Anybody can take the question, please, Dr. Bimba. Dr. Bimba.
This hormonal therapy is not sufficient. She can, as we already know, the type of hormonal therapy which can be used as monophasic or biphasic pills, they can be given continuously also for 3 months to completely suppress the spots. And along with that, we also have to take care of pain management. We have to give psychosocial support, and we have to because these young adolescents, they have a lot of psychosocial issues because of school absenteeism, severe endometriosis, and they may be given cognitive behavioral therapy also.
Yeah. So that was what Dr. Rosa was telling us to put across, that we need to advise them that they need to take help. We can always put them into the endometriosis awareness groups and have some group therapy for them, teach them mindfulness and relaxation techniques, and also ask them to practice meditation, yoga, or deep breathing. And of course, attention to nutrition is very, very important. Take up some exercises to keep them on the move, and also tell them that it is not that we can cure you of the disease, but definitely we can heal you with care. And I think that will go a long way in helping this young girl. So cognitive behavioral therapy and nutrition is very much essential along with our medical management. And do any of you have any experience with the alternate methods of pain management other than our NSAIDs? Well, we have seen in our practice, girls do respond to feel happy with acupuncture and yoga. I have not recommended TENS or herbal preparations, but of course with acupuncture and yoga, we have seen, and they are institutes where they have done studies and found that this pelvic pain does reduce. Any other opinion?
Yes, madam. I also feel the same.
Yes. So what is the role of GnRH agonists in these girls? Dr. Banushree is not there. So Dr. Indra or Dr. Banu?
GnRH agonist, it's a second line of drug after OCPLs, NSAIDs, OCP, and then progestin. So according to ESHRE to 2022, post-surgical, if at all, if we do surgery and post-surgical hormone suppression therapy will decrease the chance of recurrence. So that if they don't respond to any of the primary treatment modalities, then we have to go for this GnRH agonist.
Yeah. So there is a very weak recommendation by ESHRE for the use of GnRH agonists in younger age group because of the effect on the bone mineral density. Hence, we have to use it with caution only in refractory cases after proper counseling the individual as well as the family. Because once we give them GnRH agonists, especially under 16 years, it's a definite no, because it can have a permanent effect on their bone density. And if at all in the a little elderly adolescents, we have to have an add-back therapy, typically either norethisterone acetate or tibolone, vitamin D and calcium, along with appropriate monitoring of bone mineral density is appropriate. So we could consider it, but only after very careful counseling, and always refer to a secondary or a tertiary care setting before you put them on GnRH analogs. So I'm not going into what is add-back therapy. All of you know add-back therapy is to prevent the hypoestrogenic state and bone mineral density, the effect on bone mineral density that we need to give them either substitute progestins or combination of estrogen and progesterone, or even the SERMs can be given like tibolone or raloxifene can be given. Well, coming to the second case, I'm just rushing through because we are running short of time. We have a young girl of 19 years, comes to the ER with history of severe pain abdomen. She is married for 6 months. Her menstrual history has pain every cycle since menarche associated with backache and headaches. She was treated earlier with analgesics since 2 to 3 years, and her family physician told her, don't rest assured, you will be okay once you get married. On examination, her vitals were stable. The pain score was 9. There was tenderness, propubic movements. Because she was married, we did a pelvic examination. The cervix movements were tender and she had bleeding. There was a mass felt in the left fornix, which was tender, and there was restricted mobility. We advised a scan for her. A transvaginal scan was done. There was a 5 centimeter mass on the left ovary suggestive of a left endometrioma. The uterus and the right ovary and POD were normal. Her blood parameters and her urine examination was normal. So how do we proceed now? Dr. Geetanjali, if she's there, or Dr. Indira or Bimba can take it, or Dr. Udayan, any of you can take it. Dr. Udayan, sir?
The diagnosis is ovarian endometrioma.
Yes, sir.
5 centimeters. But then I would try, since she is only married for 6 months, I would try start with medical management, give her pain relief definitely, and surgery would not be first on my list. I would start with medical management as we had discussed, and then follow her up and ask her about her plans for pregnancy, and see if she is interested in pregnancy. We'll try to treat her for pregnancy per se. Surgery would not be the first thing on my list, on my mind.
Thank you, sir. What about the other, our expert, Dr. Anu? Or Dr. What about the other panelists? I would like the opinion of other panelists and our chairperson, Dr. Rosa.
Ma'am, we should not worry about the size of the endometrioma, ma'am. As long as she is responding for our progestin therapy, I think we should continue the treatment.
Yes. Yeah, that's the message. So don't rush into a surgical modality of management, because we all know that endometriosis medical management is got wonderful response, and then she's married, and if she wishes to have a child, as Dr. Vidayan said, we do the preconceptional counseling, put her on folic acid and ask her to try for pregnancy. Or if she does not want to have a pregnancy, we could always put her on progestins or COCs and see the regression of the mass maybe after 3-4 months, whether the mass is regressing and her pain is relieved. She could still continue with medical management, and we do not run into surgical management. So, Dr. Indra, what is the place of surgical management here?
Yes, ma'am. In this particular case, surgical management, if there is a rapid increase in the size of the ovarian cyst, so as to cause the pressure symptom, and if she has a persistent symptom and all our medical management has failed, and if we are not sure of the diagnosis, then surgery is preferred.
Yeah, very rightly said, Dr. Indra. Thank you. So, if at all you take her up for surgery, maybe due to persistent pain, not responding to medical management, so what are the surgical principles we should follow, Dr. Uday?
We should be very conservative in our approach. First of all, before going in for surgery, we should tell her that she should earn her surgery, number one. Number two, we should counsel that even after surgery, there may be recurrence, and she may get back her old dysmenorrhea and all her symptoms. And finally, we should be as conservative as possible. Just do a cystectomy, take out the cyst, preserve as much ovarian tissue as possible. Maybe pre-operative, we can always do an AMH, and just to assess her ovarian reserve. And that is all. And along with ovarian endometrioma, if she has any superficial endometrial lesions, we should try to excise them.
Yeah, we should excise them and send them for a biopsy, even though the histology may come negative. So it's very essential that when we are going in for surgery, we need to be an expert in doing surgery, because we have to do fertility sparing and damage as little as of the ovary as possible. So this is very, very important. And as Dr. Udayan rightly said, informing them and taking proper consent is very essential whenever we operate on these women.
Ma'am, one more thing I want to add, ma'am.
Yes, Dr. Indra.
We have to do pre-op AMH.
AMH,
Pre-op
yes.
and
Dr. Indra
post-op
mentioned
AMH.
that. Yeah, ideally do a
Okay.
pre-op AMH because the AMH may drop following surgery. And even regarding that, you need to counsel them and tell them. And so that's what we're going to talk about. Dr. Bimba is going to elaborate is what are you going to do in surgery? What are the points, salient points, as you said? Dr. Bimba?
As previously, yes, ma'am. As previously told, we know that laparoscopy is the gold standard for for diagnosis of endometriosis. However, in adolescent, we have to postpone it as long as possible. We should not use laparoscopy only for the diagnosis of endometriosis. Only as told by the previous panelists, only when there is failure of medical management, if there is increasing in the size of the endometrioma, and if there are pressure symptoms, laparoscopy is indicated. And that too, it has to be done pre-op. Ovarian reserve has to be assessed. It has to be done by an expert laparoscopic surgeon, and it has to be seen that it should be a one-time procedure. It has been found in various studies that if we are going to operate at a very earlier, the chance of reoperation or recurrence is much more, and the same lady or adolescent may require around 2 to 3 surgeries in her lifetime. So one time, and it has to be our best management. So when we are doing a laparoscopy, most of the time in adolescents it is mild or minimal to mild endometriosis. Moderate and severe endometriosis is dealt, but in a smaller number of cases. The presence, it may be superficial endometriosis, it can be an endometrioma, there may be deep infiltrating endometriosis. Deep infiltrating endometriosis and endometrioma are less common. However, when we put a scope, we are going to see some of the lesions as shown in this picture. Usually there might be clear vesicles or there may be red lesions. Clear vesicles, usually over the course of time, because of hemosiderin deposit, over 5 to 10 years of the time, they become powder burn spots. So these clear vesicles have to be searched by, we have to take the laparoscope as near to the lesions as possible, and then we have to take a biopsy and also fulgurate the same. And we can also fill the pelvis with saline and then visualize the spots, take the biopsy and remove the saline and come out. Or peritoneal excision should not be done because it might lead to a lot of adhesion formation. Basically, the peritoneal spots have to be detected and they have to be fulgurated. Suppose there is an endometrioma, the standard surgical procedure has to be followed. That is, you have to do a proper cystectomy, and whenever you have bleeding, we have to use minimal cautery at a very low point, and we have to avoid removing the endometrioma at the base where there may be a lot of ovarian follicles, and also we can use a vasopressin also to reduce the bleeding. These are some of the principles which we have to follow while doing surgery for endometriosis.
Yeah, excellent, Dr. Bimba. You put across all the points. You need to be an expert, do the pre-op counseling. And as you said, because the endometriotic picture in adolescents is quite different from what we see the adult endometriosis. We don't see the typical, we just see small clear vesicles. So you have very well brought out all the points, and avoid cauterization on the ovary as much as possible. You could just approximate the ovarian edges or just put an atraumatic suture also, because you should be careful that you do not damage the ovarian hilus. So this is very, very important points whenever we are doing. And just if you are not great to meet a good endoscopic surgeon, it's better you always take help from somebody, one of your colleagues who is good at it. Because if they are, and there's another option that there are instances where if these girls with endometriosis have undergone laparoscopy, you could always counsel them of placing an LNG IUS at the time of laparoscopy so that she does not have pain at the time of insertion. She has a post-operative progestin therapy which can prevent recurrence. So this is one option you should give her whenever you're doing the surgery. So, and counseling, as you already told. Okay. So now, Dr. Indra, what is the role of combined therapy? We all know combined therapy is medical therapy and surgical therapy.
Yes, ma'am. So whenever we have decided for surgical therapy, it should be followed up with GnRH analogs so that recurrence will be less.
So would you put GnRH analogs or would just a progestin be sufficient?
No.
I think a progestin would be sufficient. You need not put them on GnRH analogs. Following surgery, you give them combined therapy because it can treat the pain that may subsist in the event of suboptimal ablation, and it can slow the progression of disease. So ideally, I use norethistyrone acetate or medroxyprogesterone acetate. And of course, if she is married, you can always use an LNG IUS if there is no issues about fertility.
It depends on how she has responded initially.
Yeah. But generally, I think adolescents, I avoid GNRH analogs. What about the opinion of the panelists, the expert, and Dr. Rosa?
Madam, I normally give COCs, continuous
Yes, sir.
COCs following
COCs,
surgery.
yes.
Continuously for 6 months at a time.
As Dr. Rosa said, we have Dynogest with the oral combination, which definitely helps. You can give combined therapy, continuous therapy, or you can even give intermittent therapy. So you either give her continuous hormonal therapy, or you can only if they are not responding to this continuous hormonal therapy, then I think we should think about GnRH agonists along with an add-back therapy. I think that point is clear. Do not rush into surgery, and if you do surgery, do it with proper expertise. So now, Dr. Bimba, is endometriosis, because Dr. Sneha is apt, she has another session and she's talking on that session. Is endometriosis in adolescence an indication for fertility preservation? Such as, would you preserve the ovarian tissue?
I think, yeah, ma'am, absolutely, because we know that, yes, absolutely, the adolescents have, because they may not have fertility preservation, but this has done very well. And if possible, during the laparoscope, ovarian tissue cryopreservation can be done.
Yeah, so the guidelines do say that adolescents with endometriosis should be informed of the detrimental effect of ovarian endometriosis and surgery on ovarian reserve, and always recommend that adolescents are informed that they could always go for oocyte or ovarian tissue preservation, and tell them about the safety, the benefits, and the other implications of that. So to all the panelists, we're coming to the end of the panel. So how do we optimize management of early onset endometriosis? I think all of you have very excellently told us. I would just like to conclude with all your points.
The key is not to...
First, we are going to do an...
Yes, Dr. Indra.
Yes, ma'am. The key is not to delay the diagnosis, ma'am. So once we see a patient who is not responding to NSAIDs and we have to step up for other hormonal suppression therapy, then that's when we have to consider diagnosis of early onset endometriosis. And multidisciplinary approach is very important.
Yes. Dr. Udayan and Dr. Bimba?
Yes, I do agree with her. We should be always endometriosis minded when a patient comes early in adolescence with primary dysmenorrhea, and ask her to be on follow-up always after we give an initial 6-cycle dose of COCs. If we see she is not improving, the school absence is increasing, we should definitely go in for an imaging, and if required, we can put her on long-term progestin like Dynogest, and follow with medical management. Keep her on follow-up.
Thank you, sir. So basically, we have to be aware of this on whenever we see any young girl, and try to diagnose as early as possible. Put her on medical management initially. Reserve surgery in special circumstances, but always follow them up and do counseling and give them the proper counseling. So this is how we are going to continue this process. So we know that we have to do the medical therapy first, we have surgical therapy, and then of course we can go for the alternate medical treatment, that is mental health, diet, physical activity, and alternate systems of medicine to relieve her pain concept. So this would be an easy algorithm which we could keep with us. So to conclude, I would give you the take-home point that early onset endometriosis should be considered as a specific form with its own pathophysiology, symptomatology, and risk factors. It may originate from neonatal uterine bleeding to the seeding of the naive endometrial progenitor cells. EOE can be progressive, thereby posing a threat to future reproductive capacity of the woman. Symptomatology is often non-specific, and there is no need for simple non-invasive markers. When imaging gives rise to suspicion, a stepwise, minimally invasive approach should be utilized. Endometriosis should be considered as a chronic disease, and with the potential of progression if left untreated. The goals of therapy should be symptom relief, suppression of disease, and protection of future fertility. There is no single best treatment option. Therapy must be individualized. OBGYNs should consider patient choice, the need for contraception, contraindications to hormone use, potential adverse effects, and counsel the adolescent and her family on the treatment options. So I thank all my wonderful panelists and Dr. Parag and Dr. Rosa for sparing their time and chairing this session. I thank Dr. Anu, who has joined all the way from London on this to be the expert on this panel. I thank Dr. Udayan. I thank Dr. Indira, Dr. Bimba, and I also thank Dr. Geetanjali and Dr. Banushree in their absence due to their unavoidable circumstances, and of course Dr. Sneha Boyar also. My sincere thanks to all of you. And on behalf of KSOGA, I am contesting for the Foxy Perinatology Committee in the coming months, and my nominations will be open in the month of May. I request all of you to support me that we could work together in a higher platform for the betterment of women's health. Namaste.
Dr. Bharti, I want to say something. This is
Yes,
Anu.
please. The session is open to you now, Rosa. I'm sorry, Anu.
Dr.
Anu.
Bharti, this moderation was such an incredibly excellent moderation. I was in between two webinars, but I really wanted to come back and listen to you. It was so good. More we know you, more we get impressed by your knowledge and personality and your very gentle demeanor. And my full support from the endometriosis committee will be for you. We will try that nobody should even come against you for the perinatology committee. So my bestest wishes for you. Thank you.
Thank you. Thank you, Dr. Anu. Thanks a lot. And we are very happy to have you here. And we will continue to be together. And we will be with you in any other activities you want us to participate in.
Sure, absolutely. We will not leave any opportunity. Thank you very much. We have this Yellow Ribbon project coming up, launching on the 8th of March. I've shared the link in the chat and in the group also. So this project will be once in a month. So we will support you through these months. Thank you.
Thanks a lot, Dr. Anu. I would like Dr. Rosa to give her comments, and thank you for chairing my session, Dr. Rosa.
Ma'am, just before that, I think there is a question to be asked.
Yes,
I think
please.
Dr. Soumya Mani is.
Hello. Yeah.
Yes.
Hello, ma'am.
Hi, Dr. Soumya.
I am very well presented.
Thank you, Soumya.
Ma'am, I just want to know, is there
She is
any
our
role?
KSOGA, Dr. Soumya Mani is our KSOGA Adolescent Health Committee Chairperson.
Yeah. Hi, ma'am. Ma'am, I just wanted to know, is there any role for presacral neurectomy in adolescent age for endometriosis?
No. I don't think in adolescents the guidelines
For
do
severe
not.
endometriosis, if it is not responding to anything.
If they are not responding, a good laparoscopic surgeon, I think, will definitely be able to remove those endometriotic nodules which are causing her pain. And I think there is I have not come across any reports of adolescents undergoing presacral neurectomy. And I think even in the adults nowadays, with such wonderful laparoscopic modalities and medical management, we are not going in for much of presacral neurectomies, because if they excise those deep infiltrating endometriosis, their pain is usually relieved. And the other thing is, in adolescents, we don't see such deep infiltrative endometriosis if they catch them very early. They are all symptoms of late endometriosis.
Okay. Okay, ma'am. Thank you.
Thank you.
Madam, I think Rosa Madam and Parag sir both are not there.
Parag sir left. Okay, anyway, thank you. Dr. Vidya Thopi Madam is there. Dr. Vidya Thopi, our president, is there.
Vidya Madam? Vidya Madam, are you there?
Yeah, she's there.
Yeah, I'm very much there, and I think I had contributed one topic on alternative therapies. Alternative therapies for adolescents. So many herbal preparations are there. Acupressure is there. Acupuncture is there. So many things are there. No, they are really helpful in adolescent endometriosis. We talk of yoga. We talk of nutrition. Maybe the pathology we cannot alter. We are treating it, but sometimes there is a mild endometriosis also. And
I think we can reduce the psychosomatic impact, because this pain, depression, and there's a vicious cycle. We can break that cycle of that psychosocial impact of pain.
Exactly.
Madam, diet is very important in these patients, madam.
Yes.
Especially organic plays Yeah, plays a very important role.
And those
Yes.
gluten free and those flatulent whatever pulses which cause flatulence are to be given up, and even gluten should be given up. We should have a gluten free diet. We will do that in another
So
webinar.
these are definitely
Nutrition
helpful.
for adolescents.
Yeah. We will have on that. Yeah.
Nutrition for adolescents.
I make a appeal now as a president. I just make a appeal. We are celebrating International Women's Day, and Anu has brought that yellow ribbon. So she's launching that. So please be a part and join it. Anu, if you want to make an appeal here, you can make it. And secondly, for the International Women's Day, please send one clipping. What you intend to do in this year for women, and what is your aim and objective of life.
Yeah,
Yes.
we will send it. Inspire and inclusion.
Yeah.
15-minute video.
15 minutes nahi.
Sorry. 15
30
seconds. 15 seconds.
15 seconds is written, but
Yeah,
30 seconds. Shruti is there.
Sure.
And Shobha is there. They are
That's what
compiling. I don't know
we
when
just
they will
thought
come back.
if everybody's message, we have to combine it will be around 5 to 10 minutes. So we just restricted.
It'll be
So
7.5
we are
minutes.
sending you right away. When 30 second ka Bharti, please send it.
Yes, I will
So
send
we
it.
will compile it and we can project it.
Sure.
Yeah. Because there is no time. Tomorrow there are so many webinars. So Anu, we are joining your yellow ribbon launch.
Oh, yes. Thank you so much, Madam
All of us
President
from
of KSOGA.
KSOGA will be with you, Anu.
Yes. And you know what?
All
we
KSOGA
already
is with
can-
you.
Thank you. The 1st of March onwards,
Yes.
every day, few societies have been doing awareness programs, and there are many videos and snaps of the yellow balloons and yellow batches and yellow rangolis that they have done. We will all be showcasing that. And if I get from KSOGA, I will showcase that in the episode number 2.
Sure.
So this is the
Yes,
launch
please,
episode.
please.
So
We will do
once
that.
a month we are going to do. Yeah. And
Yeah,
this,
ma'am.
I want to
Yesterday
share
itself.
very I want to share
Yesterday
very
itself.
interesting fact that, the Chandrayaan 3 project, the second in command, the woman, Kalpana Kalahasti, she has been nominated as the Nature's world #1 scientist of this year. And
Wow.
she's coming as
Very
a
good.
chief guest
Excellent. That's really
on
nice.
8th of March. So because it's Women's Day also, so we
Yeah.
have called her. And we are also bringing the world's first boy born out of IVF, who was born from a mother suffering from endometriosis.
Yeah, I saw the
So,
photo.
Very good.
I saw your photo with
yeah.
him, Anu.
And she will tell the story. You will be so touched. It is a very special story. So I would request all of you to send the videos to KSOGA, and then whosoever will send, we will cover that in the Foxy webinar with the committee in the next month's episode. Yeah.
Sure.
Thank you.
No
Definitely.
problem.
Thank you.
No problem.
Thank you.
Wherever we go and we conduct this awareness program, we will definitely talk of this endometriosis. Definitely.
I'm so thankful to
In
you.
the
Thank
school
you.
program, adolescent. Thank you very much.
Thank you, Dr. Anu.
Please send the videos and pictures whenever possible. We will put that in the Foxy webpage of the committee that I'm
We
starting.
don't have endometriosis banner as such. Then we will send you the photos, but then you have to background photos of endometriosis committee, you have to put it.
Okay, we will
We'll
put
send you
that,
the
but
video.
I'll send you the banner anyway. You can use it in the awareness
Yeah,
activities
please.
and
I
send
think that you can do.
Yeah.
Dr. Anu, please send
Yeah,
us the
Please
PDF
send the
of
banner because
Okay,
we don't
it
have
is ready with me.
endometriosis committee as such.
We only have adolescent health
Please send.
committee. So we will
We
add
have
it.
public awareness committee.
In Gatak, Anupama Patil
Yeah,
is there.
ma'am, we have done yesterday and today
Anupama,
also we are doing.
Anupama just messaged me to,
Yes.
she has messaged me and Shruti has sent me the pictures. So
Yeah.
the pictures are there. So she will send you across. So you can put
Very
it in the
nice.
next episode.
Yes. Yes. Or maybe I will edit it, and this episode only we'll try if we get it.
Okay.
If I
Yeah.
get
No,
it in the
already she has
yeah.
sent, I think. Yeah.
Okay.
No problem.
Okay. And
Tell
Anupama will
Anupama
give
to
you the banner also. She has the banner.
Yes.
I've
Yeah,
given it
yeah,
to
We
her.
have, ma'am.
Yeah,
We
it
have
is
the
there
picture.
with Shruti, who is from
Yes.
Gadag, but
Yeah.
the KSOGA doesn't have that. So I'll
Shruti,
ask her
please.
to send to Arun.
Yeah, Shruti,
Okay.
post it on the
Since
Gatak